and gentlemen, welcome to day 2 on challenges in hematology, including best of EHA 2022 under the aegis of Mumbai Hematology Group. We are extremely proud to present this. A warm welcome to our program director, Professor Dr. M.B. Agrawal, President, Mumbai Hematology Group. Inspiration for us, teachers of teachers, and India is fortunate to have you, sir. No wonder that you got the inspiring hematologist of India by Economic Times. A warm welcome to our expert speakers today. Professor Dr. Beverley has just logged in. And also we await Dr. Drexler and Dr. Linda. And warm welcome to all the delegates who log in every day from 6:25 till 9:30. And there are delegates across 20 plus countries every day. Warm welcome to each one of you. And also a warm welcome to all the expert discussions who would be roughly like 25 in number today. May I request Professor Dr. M.B. Agrawal, sir, to take it forward from here.
Thank you, Dr. Manoj, for the kind introduction and beginning our meet on day 2. So good evening to friends from India. Good morning, good afternoon to those who are in other part of the world. Challenges in hematology, brought to you by Mumbai Hematology Group, supported by INTAS, managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS for supporting our academic activities. Mr. Yash, Mr. Kalpesh and the team from Perfect Square for managing them. Executive Committee of Mumbai Hematology Group, all our discussants who are eminent hematologists or medical oncologists, new participants for sparing your evening, morning or afternoon on a working day. Do remember to visit our website. This will give you an access to all our future academic activities, mhgindia.com. Day 2. And our first speaker is Professor Beverley Hunt from London. She's Professor of Thrombosis and Hemostasis at Thrombosis and Hemophilia Center at St. Thomas Hospital, London. And she's going to speak to us on postpartum hemorrhage. Over to her. You are muted.
So, thank you very much for that nice introduction. I hope you can see my slides and I hope they're in the format that you're used to. You can't see down the side, just see the slides. Okay. So I am going to talk about postpartum hemorrhage.
Make it slide. Yeah. Can you make it slideshow mode?
Yeah. There we go.
Yeah.
So I am going, is that okay?
Perfect.
Yeah. Okay. So I'm going to talk about postpartum hemorrhage, but as a global issue. And I'm very passionate and angry about postpartum hemorrhage. And I think many women are, and I just want to share with you the state that we are in. So I'm going to discuss the impact of postpartum hemorrhage, the wider impact on people's lives, where we are with the very small amounts of research that are going on, where we are with management and where we need to go. So I just want you to think first about the fact that a woman dies of postpartum hemorrhage every 4 minutes. Every 4 minutes. Somewhere in the world, a woman is dying of this medieval problem because this is something that we could prevent and it's not happening. And of course, 99% of the deaths are in low and middle income countries. And actually, they account for 1 in 200 deaths globally. So this is a significant problem, taking away healthy women from our society. But it's more than the fact that the women die. We have major social economic consequences. So the surviving children are much more likely to die too because of the loss of their mother. They have poor nutrition or reduced schooling because the eldest may be staying at home to look after the youngest and therefore missing out on education. So there's a cost to it, and the WHO have estimated that it costs about $15 billion in lost productivity every year. And the lack of support for maternal health cuts the country's economic growth. If we could support maternal health more, we would cut poverty and we would reduce maternal death and disability. And so this really is a human rights issue. And I also think it's a feminist issue. So let's go back to what is postpartum hemorrhage. And we expect some blood loss after delivery, and it's physiologically tolerated normally unless there's a significant pre-existing anemia. And I'm going to come back to that point. So if we have minor hemorrhage, it's anything between half a litre to a litre. This is the majority of postpartum hemorrhage. But what we fear is major loss, so that's more than a litre, which occurs in 4% of the UK deliveries, and severe is losing more than 2 litres. And thankfully in the UK, it's less than 1% of deliveries. So let's look at why this problem gets neglected. And here we have the global burden of disease. So this is deaths that occur every year. The WHO estimate that there's 55 million deaths a year. And if we look at the deaths, they're according to age. So we're from 0 to 6 age, really early on, right up to the age of 95. And the main color that you see from 15 to 95 is the blue, and that's non-communicable disease. So it's cardiovascular disease, cancer, respiratory disease. Those are the diseases that the WHO was concentrating on before the pandemic because they cause most death, because they are preventable. So diabetes and obesity and smoking and other environmental factors will all influence those. Running along the bottom is trauma, and trauma's green and accounts for 9% of all deaths. And this is anything from road traffic accidents, which accounts for about half, a particular issue in low and middle income countries, and then interpersonal violence, wars, and suicides. But if we go down, if we look at the red, in the red, we have got tropical diseases and malaria, and buried in there, why has it been put in there, is that we have maternal disorders, and included in the maternal disorders is postpartum hemorrhage, and it's not singled out from the other causes of maternal death. So you can see it's very much lost in the way we look at death. If we look at maternal mortality, we know there's approximately 300,000 women who die from causes related to pregnancy and children. And this is an estimated figure because of the low status of women in some countries. Their births and deaths aren't so well registered. But what we know is that if we look in North Africa, of those deaths, 40% are due to hemorrhage. And even in the developed world, where the number of deaths in each country you can count in the 20s or 30s, 16% are due to postpartum hemorrhage. So if we look at our UK maternal triennial inquiry, and so in the UK, we have to do a post-mortem on any woman that dies, either in pregnancy and the postpartum period, and look at the cause of death. And it's enormously helpful to be doing that. So over the last 20 years, you can see venous thromboembolism remains an ongoing problem despite staggering amount of thromboprophylaxis that we use in women. Preeclampsia and eclampsia, we seem to be managing better and better. But at the bottom, we've still got 17 women a year dying from hemorrhage. Now, that's a very low rate compared with the low and middle income countries, and obviously something's going on, and that's modern care. So if we do have a woman who has a major hemorrhage, we can offer all sorts of therapy, anything from hysterectomy, which can be life-saving, to radiological procedures to reduce the blood flow. So if we look further at the data that we have, and this is US data, and I have to tell you that it's sorely out of date in the sense that this is 2019, and actually now the major cause of death in the US in pregnancy is actually gunshot wounds, as it is the #1 cause of death of children is gunshot wounds. But let's look at postpartum hemorrhage. So it accounts for 11% of US maternal deaths, and it's the leading cause of death on the day of birth. And when these deaths are looked at, as they are in the UK, you can argue that 50 to 90% of them are preventable. Now, in the US, they say the major factor in the deaths is the failure to identify early postpartum hemorrhage. So there's inaccuracies around the healthcare provider estimating how much blood has been lost by just looking at external losses. And of course, a uterus that's not contracting down can really fill up with blood, and there might only be an external trickle of blood. So that's really not the way to measure it. And we know that visual estimates of blood loss is notoriously inaccurate. People underestimate small amounts and overestimate large amounts. So perhaps they need to think about better quantification. It certainly is an area that needs further research. When we look at the primary causes of postpartum hemorrhage, and this is taken from the woman's study, which I'm going to talk about later, which I was part of, you can see that the majority are due to the failure of the uterus to contract. The typical patient being a woman who's on her 4th or 5th pregnancy, and there's just poor tone in the uterus. Second is surgical trauma and tears, accounting for 21%. Then we've got abnormal placentation, and we've got other causes too. And I think what's quite interesting is the rise of abnormal placentation as a cause of postpartum hemorrhage. So if you look at New York State, where there's a lot of intervention in pregnancy, high rates of assisted conception and cesarean sections, it's actually the most common cause of death due to postpartum hemorrhage. And the incidence is also rising fast in China because they too are increasingly using medicalization to have to start pregnancies and also have an increasing cesarean section rate. So the main causes are previous uterine surgery, so that's cesarean section, previous ecresia. So if you've had one in a previous pregnancy, you're more likely to have it in the second. Increasing maternal age, and we know that the age of women having their first child is increasing in high-income countries, and assisted reproductive techniques. The other interesting factor, perhaps not such a big player, but worthy to talk about to a hematology audience, is the role of thrombophilia. So in the Caucasian or the white population, we know that factor V Leiden is very common. The first abnormalities of factor V Leiden probably started in the Middle East and moved out across Europe. And we know the prevalence of factor V Leiden in its heterozygous state is about 10% in Turkey and around there. And then in the UK, in white people, it's about 5%. And the question is, why is it so prevalent? And really, up until our Victorian times, beyond our Victorian times, until we had better maternal care, so I'm talking about the last 100 years, postpartum hemorrhage was a major cause of death in pregnancy. And the argument is with factor V Leiden, you bleed less when you have a bleed. So it protects women from severe hemorrhage and postpartum death. And that might explain why it's so prevalent now. And then the other factor is tissue factor. So tissue factor is present on all cells. And if you have a polymorphism where you've got increased tissue factor expression, then it seems to have a protective effect against postpartum hemorrhage. But of course, the modern world is all about preventing massive obstetric hemorrhage, and the keys have to be preventing anaemia early in pregnancy, infusing healthcare workers, the midwives, the people who see the women early in pregnancy to get that woman's hemoglobin, if it's low, up to a reasonable level before delivery. Then we need to identify the high-risk cases, such as placenta accretia with scanning, and then actively manage the third stage. And of course, we use uterotonics to do this, and they will deal with most causes of massive hemorrhage, but not all of them. And this Cochrane review looked at the many available and argued that ergometrin plus oxytocin combination was probably the best, and went against the current WHO guidance. Let me take you back to anemia. So when we did the woman study, which we recruited 20,000 women across the globe who had postpartum hemorrhage, what was quite shocking was the level of hemoglobin in the women who were in low and middle income countries at the time of delivery. Much lower, and usually iron deficiency in these groups. And I just want to remind you about the effect of the hematocrit on the bleeding time, because once your hemoglobin or your hematocrit falls to a certain level, you lose axial flow. So once your hematocrit is less than 30%, you lose axial flow. And axial flow is that mechanism whereby all the red cells will flow down the middle of an arteriole, pushing out all the platelets and the plasma towards the endothelium. So if there is a cut in the endothelium, the platelets and the plasma are there to manage that hole and form a clot. And if you have a hematocrit much lower, you lose that axial flow. So it just takes physically longer for the area that has been damaged to heal or to form a clot, because the platelets are elsewhere, as is the plasma. And then our other issues, our blood supply is fragile in low-income countries. And if we look at the number of blood donations collected globally, so that's over 100 million blood donations a year, 42% are collected in high-income countries where only 16% of the world's population live. But in 58 countries, we've got the issue that 50% of the blood supply is dependent on a member of a family stepping forward to replace the blood that's been used, or they get paid blood donors. And of course, only a minority of countries are necessarily producing all of the plasma-derived products that we could be using in managing a massive obstetric hemorrhage. And then when we look at the practice in high income countries, there's no agreement. There's no high quality evidence to know how to manage an obstetric hemorrhage. So if we look in the world of trauma, the current data in trauma says if you have someone bleeding out, you should give them blood products of red cells, fresh frozen plasma, and platelets in a ratio of 1 to 1 to 1. But there are no trials at all in managing massive obstetric hemorrhage to know whether this is best for women who are bleeding or whether we should prioritize with certain products. And then when we look at Europe, we all have national tendencies. So here in the UK, it will depend whether we have a good intervention radiologist available who can do embolization. But in France and Netherlands, they definitely prefer to use surgical embolization. And in the UK, the obstetricians use compression stitches around the uterus more than anything else. So is obstetric hemorrhage different from non-obstetric hemorrhage? Well, let's remember the starting point is different. So women have really prothrombotic changes at term, unless they've got bad preeclampsia, but we've got really high fibrinogen levels. Their coagulation factors are all increased, double normal levels of 1 Willebrand factor and factor 8. So the PT and APT are really shortened. We've got reduced levels of physiological anticoagulants, especially protein S. It falls like a stone as soon as you get pregnant. And fibrinolysis is switched off. When we look at term, the red cell and the platelet mass for a pregnant woman are greater than a non-pregnant woman, but because the plasma volume increases more than the red cell and platelet mass, the actual indices themselves are lower. And we come back to this issue of when somebody with trauma bleeds out, you see the blood in front of you. So you can guesstimate roughly how much has been lost. In women with obstetric hemorrhage, especially postpartum hemorrhage, the blood may be collecting in the uterus, so it's hidden. And your other problem with a healthy woman is that the changes that we see in elder people, so the fall in blood pressure early on when people are bleeding out does not occur. Women will vasoconstrict enormously, so they get a marked tachycardia, a marked respiratory rate, but a pre-terminal event will be the drop of blood pressure. Monitor pulse rate and respiratory rate. And the last thing to say is this little shorthand thing that people use in obstetrics, in that they say, is the cause due to changes in tone or trauma or something wrong in the tissues, or is it the patient has a coagulopathy, which is why the word thrombin is used. And just a reminder that one can really bleed out at term because 10% of the cardiac output goes through the uterus. Now, over the last few years, since this particular paper, a French paper from Charbot, which showed that fibrinogen is an early predictor of the severity of postpartum hemorrhage, there has been quite a lot of thinking about fibrinogen in postpartum hemorrhage, although it hasn't translated well into clinical trials. But we do know if you find a fibrinogen less than 2 grams per litre, you know that that woman is going to be highly likely, well, 100% likely to have further bleeding. So there's been a global look at how we can perhaps use early hemostatic monitoring at the bedside to pick up on these changes quickly. And thromboelastography certainly fulfills that criteria. So we collect some blood, we put it in a rotating cup, and we watch how long it takes before it starts to form a clot. And I've just shown you here the normal woman, the normal trace, and then the healthy pregnant woman on the right. Well, we've got a very wide maximal amplitude, which means it's very prothrombotic. Most of that change is due to the very high levels of fibrinogen. And you can see at the bottom, this is a woman with a platelet count of 40. She's still got a prothrombotic tag because of that very high level of fibrinogen. It compensates for that fall of platelet count that we see in pregnancy. So the best proponents by far of using some form of thromboelastography in pregnancy are this husband and wife pair, Peter Collins, he's professor of hematology in Cardiff in Wales. Rachel Collis is a very eminent anesthesiologist who works closely with them, and she only does obstetric anesthesia these days. So they have had the most amazing effect on the country of Wales, 3 million people. I think we've got 10 to 20 sites where women deliver, and they have totally taken over Wales and put a ROTEM, which is a form of thromboelastography, into all of the delivery suites. And they, if they have a woman who looks like they're bleeding out, they will do thromboelastography and particularly measure fibrinogen levels with a test known as FibTem. So that will give you within 20 minutes a reliable-ish fibrinogen level. And so if someone is bleeding out or they got a tachycardia or they're not looking right, they can have this test done and you can see whether or not they have a fibrinogen problem. And so they can pick up on those who've already bled out quite a bit and pay attention to them. But also those women where they're worried about, it's very reassuring to have a normal FibTem. So the consequence of these changes have meant that they are actually using less blood components in their obstetric centres because you can separate out those that actually need blood, that small minority, from all of those who you're not sure about and you want to do something, so they end up being transfused. That doesn't happen anymore in their centres. So they've done an early clinical trial. Anyone who's got a postpartum hemorrhage of 1 to 1.5 litres is enrolled, and they randomized them if they had a FibTem lower than 15, which is equivalent to a Klaus fibrinogen of less than 2, of giving them fibrinogen concentrate versus placebo. And the primary outcome was the number of units transfused afterwards. So here we go. We've got 663 women who look like they've had a significant blood loss, and yet only 55 have a low fibrinogen. So you know you're not going to need to transfuse the other 600. You've just got those 55. They were randomized to fibrinogen concentrate or placebo. And you can see if you got fibrinogen concentrate, you had fewer blood products than those who got placebo. So we haven't really got a statistical difference, but we need to take this work out. And I know that they're working on a much bigger multi-center trial to repeat this work. So I can't talk about postpartum hemorrhage without talking about tranexamic acid or TXA. And we know that this tiny molecule, which is a lysine analog, is a physiological competitor for plasminogen. So it actually binds to the plasminogen receptor and stops it binding down to fibrin. And so we come to the woman study, which was published a few years ago now, where they looked at the effect of TXA on death, hysterectomy, and other surgical interventions and thromboembolic events in women. So these women were recruited from all over the world. The UK contributed about 5%, but mainly they were women in low and middle income countries. And you can see that despite this being a difficult situation when you have a big postpartum hemorrhage, they were able to randomize women within an hour of birth for nearly half, and then within 3 hours for 75%. Most of these women had delivered placenta. I talked to you about the breakdown of causes, and you can see at the bottom that 80% still had an adequate systolic blood pressure. Now, there was a death rate, as expected, of about 5%. And this is the start graph looking at when women died and what was the cause. And you can see that the majority of them died within 24 hours. I should say that these centres that involved mainly had women who were delivering on site, but occasionally there was a centre where women might be brought in from another maternity centre, having already started bleeding. So this picture is very similar to trauma. When people die of bleeding from trauma, it happens pretty quickly. So let's look at the first 24 hours, and it does look like women are exsanguinating to death very quickly, with the majority within the first 4 hours. You can see there's a few pulmonary emboli in there too. So when we come to look at the final analysis of this group of women over 20,000, you can see that there was a reduction in the number of bleeding deaths, and it reached significance. Importantly, when we look at pulmonary embolism, because you're giving a drug that is affecting hemostasis, always worried about a hemostat increasing the risk of thrombosis, no increased rate of pulmonary embolism, organ failure, didn't provoke sepsis or eclampsia. There was no associated problem. And when we look more closely at the thromboembolic events, we can see in the breakdown we've got similar rates of arterial and venous events. So this is very similar to the CRASH-2 trial, which gave 20,000 patients who were bleeding with trauma TXA, and we're talking about giving 1 gram when the woman starts bleeding, and then maybe another gram later on, much the same as in the CRASH-2 trial. And again, in the CRASH-2 trial, where we're just having TXA once off, there was no increased rate of thrombosis. So when we do a forest plot and compare postpartum hemorrhage with trauma, so that's the data from the woman study and CRASH-2, you can see we're getting very similar effects. There's evidence of huge benefit in reducing death due to bleeding if given within the first 3 hours. But if you give it late, so that's more than 3 hours from delivery or more than 3 hours from the trauma, you have evidence of harm. And I suspect no one's really looked at it properly, that if you continue to bleed out, you get very, very hypoxic and you trigger off a disseminated intravascular coagulation. And in a disseminated intravascular coagulation, you are dependent on fibrinolysis to eventually break down those clots. So you do not want to give a drug like TXA. This is another way of looking at it. This is from a very clever statistician saying, what is the benefit of TXA according from time from delivery? And the survival benefit decreases by about 10% for every 15 minutes delay that the TXA isn't given. So if you get to postpartum hemorrhage, you need to give 1 gram of TXA as soon as possible. It is a medical emergency. So now the WHO recommend early use of intravenous TXA and reminds everybody most deaths occur very early. That's why you need to get on with it. Now, TXA is an interesting drug because if you give it to try and prevent blood loss, it doesn't have an effect. And this huge study from France, from Saint-Hillies, published in the New England Journal of Medicine, randomized nearly 4,000 women with vaginal delivery to TXA versus placebo, and there was not a significant reduction in the number of cases who had postpartum hemorrhage. It looks like there was some very minor effect, but really there was no difference in blood loss and no difference in the rates of postpartum hemorrhage. What they did pick up on was that if you give TXA, that you might get nausea and vomiting, and occasionally people actually get a change in the color of their vision, not seen in this trial, but certainly seen in some of the hemophiliac trials where they use TXA. And again, looking at the thromboembolic events, no difference in DVT, PE, or any other form of venous thrombosis. So it's really giving us a clue about what's happening to peripartum fibrinolysis. And there's such little data. I've done some work in my lab, which we never published, I'm afraid to say, but we did look at fibrinolysis in 20 women with normal vaginal deliveries. And you can see if you look at D-dimers, really not much of an increment. And the key factor, tissue plasminogen activator, doesn't really increase during delivery as it does in trauma and as we presume it does in postpartum hemorrhage. Not much change in thrombin generation, fibrinogens are okay. And then we've got this older paper from Steve McKinnon from 1987, again looking at TPA and fibrinolysis in different ways, the old-fashioned technique of fibrin plates. Again, very little difference. So we shouldn't expect TXA to work in a preventative way because there isn't any evidence of fibrolytic activation in normal delivery. What is always important in any aspect of medicine, and PPH is no different, is having a protocol in place to manage your patients. So this is more US data. They employed a nurse to run protocols in postpartum hemorrhage in 29 hospitals with 60,000 births. And their job was to run this protocol to keep the hematocrit over 24%, keep the INR at a reasonable level, platelets more than 50,000, and fibrinogen greater than 1. And doing it and treating these patients early meant there was a reduction in the utilization of blood products, presumably because you catch it early, you don't go on to a major problem. And this is really confirmed in the fact that there was a reduction in peripartum hysterectomy, so fewer uncontrolled massive bleeding episodes. So what are we meant to do? It's 2022. We have very little help from clinical trials as yet with managing PPH. Well, what should we do? We should give TXA 1 gram as soon as possible. Maybe we should be giving red cells and FFP immediately. There is a great argument for checking the coagulation screen and full blood count or using thromboelastography. And then this very old-fashioned recipe of, well, if you've got a prolonged PT-APT, give FFP. If you've got a low fibrinogen, give cryoprecipitate or fibrinogen concentrate, and give platelets if the platelets are low. And the last piece of advice as a thrombosis doctor is to remind everyone that if you have a postpartum hemorrhage, there is a higher rate of venous thromboembolism later on, so we need to start thromboprophylaxis as soon as possible. The problem is, where is the evidence? So TXA, it's there. Big randomized controlled trial shows enormous benefit, but we have no trials looking at how to manage women with postpartum hemorrhage. So where do we have to go? Well, the woman trial shows it's actually possible to be doing meaningful trials in obstetric hemorrhage, which people said were not possible with the current rules that exist, and also the need for the staff on site to get on with managing the woman. But we really do need a major international effort to improve the care of postpartum hemorrhage, similar to the attention given to trauma over the last 10 years. And I say this because tomorrow I'm going to a meeting, a private meeting with 50 trauma researchers, looking at all the work that we have done and seeing how we can take that forward. It's paid for by a benefactor. This is not happening with postpartum hemorrhage. There's so few people working in this area. We need to know, what are the hemostatic changes in PPH? Then we can better work out what trials to do of using blood products. We also have the issue of availability of blood and TXA in low and middle income countries. I know there are many countries across the world, despite TXA being declared a WHO essential drug and only costing $5 a gram, they just don't have it in their pharmacy. And we need trials. We need to look at where we go with management. Many women give birth outside of a hospital setting. We have in development intramuscular TXA for use in the army in case they have traumatic bleeding. And the plan is for every soldier in armies to carry intramuscular injections of TXA as they carry tourniquets. Maybe we could do this too in postpartum hemorrhage. And do these women really need, if you have it available, fresh frozen plasma up front, as the trauma trials suggest? So I'd like to thank you very much for listening, and I look forward to your questions. Thank you very much.
Thank you, Professor Beverley. That was fantastic, an eye-opener. You have really given something which is very frightening. One had not realized the degree of problem that you have mentioned. We have our colleagues who have put raise hand sign. They would like to ask you some questions. Before they start, I just wanted to ask you one question about how often Novo 7 is used in this situation in UK.
It's not licensed for use in pregnancy. It's just got a European license based on, and I'm sorry I didn't mention it actually, but it's not globally available. But the evidence supporting its use in postpartum hemorrhage, from my view, is very poor. So we don't have it available for postpartum hemorrhage here, and the recommendations are not to give it unless it's part of a clinical trial.
Right, thank you. Dr. Jyoti, your question. Sorry, yeah.
I was wondering, do you use Nova's recombinant 7A?
Available here, and there has been desperate use in certain institutions. It has been around for last 10 years, so people have used it.
That's the problem. It's used in desperate situations, and we know the data shows very high rates of arterial thrombosis. So I know that the new data coming through, which is not published yet, the European licensing agencies have licensed recombinant 7A for obstetric hemorrhage on unlicensed data, unpeer-reviewed. So it's going to be interesting to see this data when it comes out.
Thank you. Dr. Jyoti.
Professor Beverley, a fantastic talk, and it's something close to my heart. I'm a hematopathologist, very interested in coagulation and have recently in the last 2 years done a trial convincing the gynecologists first to get fibrinogen done in their PPH cases. And then we worked on ROTEM. We did this trial on 100 ladies who had delivery. I became a co-guide for a fellow doing gynae and obstetrics. So that's how I could do it. And we did find a very good correlation with the fibrinogen levels and the 5-minute FibTem in the ROTEM. So that we got a square of 0.7. I presented it in 2019, the conference also, which was online, 20 conference during COVID. And we did find, and now our gynecologists are convinced, they get the fibrinogen done and they give cryo. We don't have fibrinogen concentrate in India, so we give cryo. And from going into that, because the physicians, it was very difficult to convince the physicians who were treating these ladies when they had PPH that don't give FFP, give a cryo depending on the FibTem or the platelets, depending on the values at A5 of the XTEM and the FibTem values, as well as the fibrinogen and the CBC and the coagulation factors. But over these 2-3 years, we've been able to, at least in my hospital, which is a tertiary care teaching hospital, but I know of many gynecologists, even my college classmates who are gynecologists, that fibrinogen concept and that concept of looking at fibrinogen crash down below 2 grams is still not there in our country. And I think that's not even in the national guidelines.
Is it not? Well, well, first of all, congratulations to you for being a champion for postpartum hemorrhage and doing all this work to improve care of your local women. It's outstanding, so well done. And how are you going to change your national guidelines?
Well, that's an issue. But I've been lucky to have just got into the patient safety committee of the government of India. So hopefully I'll be able to now push it through in the next 2 to 3 years, the result of what we have done. And just by talking and meeting the gynecologists and trying to convince them, please get a fibrinogen done if you have a patient having PPH, is what I'm trying to do. But it's something which is, I also just read about it, and then we had these patients coming. And then the other issue is like after about Novo 7, we have given to 2 patients where we had acquired postpartum hemophilia and they were pouring. So there it did work. And we thankfully didn't have any arterial thrombosis. But most cases we've been able to manage in the last 3 years since I've been doing this in my hospital. We've been able to manage them with the blood products, evidence-based requirement of the blood products.
Well done. Well done. And yes, of course, you use recombinant 7A in acquired hemophilia, but it's not really a proper indication for PPH yet.
Yeah, there's only 2 patients who had PPH because of acquired hemophilia. There we used it.
Very good. Very good.
Dr. Jyoti, a little information to you. Fibrinogen concentrate is officially available in India for last about a year.
Okay, so but in Delhi, it's not in our hospital, so that's
so insist on your pharmacy to have it. The sponsor of this program today, Intas, makes it. It's available as a drug.
We'll get it, the details. I'll get the gynae.
Right. Cryo is just as good. In some ways, you could argue it's better because it has lots of other things in it which are very useful. So the arguments about which is better, cryoprecipitate or fibrinogen, keep going on. No one knows the answer.
Yeah, what has happened is that the making of cryo has disappeared with factor 8 concentrates available. So blood bank is no more making cryoprecipitate very easily.
Okay.
So fibrinogen is now kept in the labor ward. So it can be just picked up and given in no time. So
very good.
Yeah, Dr. Prashant.
Thank you, ma'am. It was a wonderful lecture. As you stated, or as the data suggests, most common cause for this PPH is being the abnormal placenta. Either placenta accreta or percreta or all these things. Now we know that upfront, most of the cases we know that the patient has an abnormal placenta upfront through ultrasound. So do you suggest for such patients routinely screen for fibrinogen level or APTT? And if the APTT is not less, if it is in a normal range or prolonged, to go for actively checking for fibrinogen levels?
So I don't know in India whether abnormal placentation is the major cause of bleeding. I would have suspected it was uterine atony. But are you saying in your center abnormal placentation is the main cause that you see?
Yeah, no, if the patient has an abnormal placenta, that data we will know before the delivery itself. The ultrasound will pick it up. So do you suggest for such patients, active screening for coagulopathy or hyperfibrinogenemia in these patients?
Well, unless they're bleeding, they won't have a low fibrinogen, will they?
No, there are certain data. No, there are certain data that baseline fibrinogen level less than 2 grams. The patient chances of PPH is higher, and the PPH is going to be more severe.
Yes, that data was looking at women who are actually bleeding, and so by the time they drop their fibrinogen to 2 grams, then they're in really big trouble, because the normal fibrinogen at delivery is somewhere between 5 and 7 grams per liter. If I saw a woman with a fibrinogen of 2 grams at term, I'd think, oh, she's possibly got a dysfibrinogenemia or hypofibrinogen states, and actually investigate her, because that's too low. So when patients are being managed and giving birth with abnormal placentation, they need to be closely monitored. And if they start bleeding, I would actively manage them, yes, by regular coagulation screens.
Oh, thank you, ma'am.
Thank you. Dr. Amit?
Just continuation of the previous question. If the fibrinogen is less than 2, patient is not bleeding, so do you recommend giving cryoprecipitate or fibrinogen concentrates for this patient? Patient is not bleeding.
No, so I wouldn't be measuring the fibrinogen. So if someone gets to term, if someone's got a fibrinogen outside of pregnancy, 2 is normal, isn't it? So I'd never give fibrinogen to anyone who had a normal fibrinogen, and I don't give blood products to people unless they're actively bleeding. Is that clear?
Yeah.
Okay.
Thank you. Dr. Shailendra? No, we can't hear you, Dr. Shailendra.
Now, am I audible?
Yes.
Yeah. So, ma'am, do we have any, predictors of this postpartum hemorrhage, so that we can predict in a particular, female that she's going to have PPH?
So that's the problem with postpartum hemorrhage, is that it's not always predictable. So we know older women, and we know that they are more likely to have uterine atonia. Being anemic, they're more likely to bleed more. And then we've got the issue of abnormal placentation being a cause if they've had previous surgery, so previous cesarean sections, and also if they've had assisted conception. For some reason, there are higher rates of abnormal placentation. But I mean, postpartum hemorrhage, if we look at the majority of the women with uterine atony, they're usually 4 or 5 pregnancies down the line. And often, I mean, I'm looking at low income countries, so maybe they get married at 14 and they have their first baby at 14 in the summer, and they're already a little bit iron deficient. And then the following year they have another baby, they're a little bit more iron deficient. So by the time they get to the 4th or the 5th pregnancy, they start the pregnancy out maybe with a hemoglobin of 80, and they drift right down to 60, and they have uterine atony, and that combination of anemia and the problem you've got with the prolonged bleeding time, they're just going to be victims of dying of postpartum hemorrhage. So I don't think you're seeing that, are you? You have better care than that. But that's certainly what we were seeing in some parts of Africa where there's just no real antenatal care.
Yes, ma'am, because the institutional delivery, there is no problem. Blood is available, within time.
Yes.
But for, non-institutional private sector deliveries and all, it's a very big problem because the PPH is so severe that there is no time even to, arrange blood and blood products. So just I wanted to know that, like we are discussing fibrinogen, can it be one of the predictors, like you mentioned that it should be in the range of 5 to 7 grams because of, pregnancy. But if it is low, maybe 2 or 3 grams before delivery, if we measure it, can it be one of the predictors for, postpartum hemorrhage? Like
So
you mentioned,
I haven't ever seen, yes, I understand what you're asking, but there's no research in that area. And I've never seen a woman with a fibrinogen of 2 to 3 grams at delivery. They're always elevated. But then I'm looking at my population of women, and they're mainly, well, they're from all over the world. They're well nourished. 20% are obese. They're all different ages. We just don't see fibrinogens of 2 to 3 grams at delivery. And it would be interesting if you did, because we don't.
thank you.
Thank you. Dr. Krishna?
Thank you, sir. How do you manage patients who have a pre-existing coagulopathy? Are they at increased risk? For example, somebody with von Willebrand's disease or a platelet problem like Lanzmann's, are they at increased risk for PPH? And how do you manage them through the postpartum period? Do you have to give any factor replacement in anticipation or have a high degree of suspicion?
So that's a big area. And if we firstly think about type 1 von Willebrand's disease, they usually have levels of 50% of von Willebrand factor or much less outside of pregnancy. But one of the effects of pregnancy is to double your level of von Willebrand factor. So the normal woman at delivery will have a von Willebrand factor level of about 200%. And somebody who's got type 1 von Willebrand's disease will normally have a level of about 70 to 100%. So they will have enough fibrinogen to deliver. The problem is the few days after delivery when they have very low von Willebrand factor levels, and then they're likely to bleed. So we often keep them in, we monitor their von Willebrand factor levels, and we'd give TXA if we had any concerns or if they had excessive bleeding. But for all the other inherited bleeding disorders, they're each managed in their own way. And I think it would take another hour to do that lecture. So I would suggest that you look at the guidelines, the British Society for Hematology guidelines on managing inherited bleeding disorders is very good at covering pregnancy. Thank you.
Thank you. Dr. Amrita?
Good evening. And so one question I had was how relevant are viscoelastic assays, TEG and Boston, for actively hemorrhaging patients, postpartum patients? So how often do we do viscoelastic assays for such patients?
Is the question how relevant is doing thromboelastography?
That's correct.
Yes. So if a woman is bleeding out, you need to monitor with coagulation screen and platelet count, and ideally a hemoglobin as well, or you can use thromboelastography. Some of us have got labs where we can do a full blood count and a coagulation screen, and we can get them back very quickly. And so in that setting, thromboelastography is not so relevant. But if you don't have all of the tests and with a fast turnaround time, then thromboelastography is very useful because it will tell you what's going on with the coagulation. And as I said, the Collins team, they found it was so useful to say this woman doesn't have a coagulopathy, and everybody could relax, so they didn't have too big a bleed. And then they'd find just a minority of them with significant coagulopathy, and so you can concentrate on them and give them the relevant blood products.
Okay, another thing I wanted to ask was in type 2B von Willebrand disease, I guess platelets are a contraindication. So in an actively hemorrhaging patient, how do we give just desmopressin and von Willebrand factor concentrate if required? I mean, without platelets, just wanted to know how would you manage a type 2B von Willebrand disease?
Yeah, so I think platelets are contraindicated, but you can use TXA as well, can't you? And you'd want to use von Willebrand factor too. And obviously you'd need to monitor it with a good lab, or you'd have already done some work on that lady knowing how she responded to the von Willebrand factor. So you are managing von Willebrand factor in pregnancy, von Willebrand disease in pregnancy, are you? You are managing that.
Yes, we do.
You
get
are
additional
managing
cases.
women. Okay, very good.
Thank you. Thank you.
Very good.
Thank you. Dr. Shruti.
Good evening, Professor Hunt. And I'm a pediatrician actually, so I don't have much experience with PPH. I just had, one little query. Like now, a lot of centers in India have intervention radiology available. So we have access to embolization and it can be done. But the biggest problem, I'm actually not talking of PPH. I'm talking of other scenarios where we have to, go for embolization. A lot of times our patients with ITP are the ones who need it. And the usual response we get is, the platelet count is below 50,000 or so. We cannot do an embolization. So do you use any cutoff for an embolization, any platelet cutoff for embolization, or it can be done in any patient, regardless of the platelet count?
It depends on the confidence of your intervention radiologist, doesn't it? So I have available an intervention radiologist who doesn't worry too much about a platelet count. And similarly, I have a very old surgeon who will take spleens out of patients who have ITP if they've got a platelet count of 5. He'll say, oh, it doesn't matter. I'll just do very good surgery. So it's the confidence, isn't it? And we need to encourage our intervention radiologists to gain experience widely and build up their techniques.
The other thing which I wanted to ask you was I was quite, kind of not surprised, but a little amazed that iron deficiency anemia is like kind of associated with more bleeding, because in pediatrics, at least, we see a lot of thrombocytosis and it is actually a cause of stroke. So, I mean, how is it so different when it comes to PPH?
Because as I tried to explain, if you're anemic, then you have a prolonged bleeding time. Your blood doesn't flow correctly and it takes longer for the blood vessel to form a clot. So yes, iron deficiency anemia is associated with increased rates of thrombosis, but paradoxically, if you are bleeding, you will bleed for longer. And it's a reflection of the complexity of hemostasis and why all the people on this call, apart from you, will never be out of a job, because it's so difficult to manage patients with thrombotic and bleeding problems.
Thank you, Professor.
Thank you. Dr. Chandran?
Excellent talk, Professor Hunt. My question, you were mentioning about thromboprophylaxis in all the case of PPH, but is it irrespective of the values of prolonged PTA, PTT or low fibrinogen, or for every patient you're going to advise?
So once a patient has stopped bleeding from PPH. And if their coagulation screen was normal, I'd give them a standard dose of thromboprophylaxis within 6 hours. If they had abnormal values, I would delay giving them the thromboprophylaxis until the following day. But then I would start them on thromboprophylaxis, because after you've had a PPH, you have a huge acute phase response. So you do get quite marked prothrombotic changes. Thank you.
Thank you.
We have 1 or 2 questions in the chat box. The patient is bleeding and the fibrinogen is about 2 grams. Will you still give fibrinogen, or is there any other way to control bleeding?
Well, you have to remember, I'm talking about the hemostatic management of bleeding. So I'm presuming that this patient is getting uterotonics as well. And if they have ongoing bleeding, they're thinking about some form of surgical procedure. So, I mean, if the patient keeps bleeding, their fibrinogen will be eventually less than 2 grams. So I'm just talking about the hematological aspects of the bleeding here. So I think it depends on the patient and what else is happening to the patient.
The last question we have is there a target fibrinogen level that we should maintain when a lady has PPH?
Over 2.
Over 2.
Over 2.
Yeah. Thank you, Professor Hunt. That was the last question. Extremely grateful to you for having spared your time, giving this lovely talk, really opening up our, we really were not aware of the magnitude of the problem, which you expressed and made us conscious, and a lovely question answer session we had. Thank you so much for being with us. Yeah, indeed.
Thank you for the questions. There was very thoughtful people, they're very thoughtful people there. So thank you.
Thank you so much.
Okay.
Now it's my pleasure to introduce the next speaker of the day. We have Dr. Beatrice Drexler from Switzerland, and she's from the Division of Hematology, University Hospital Basel, and she's going to speak to us on thrombopoietin mimetics in aplastic anemia. So over to her.
Yes, thank you very much for the invitation. I'm very happy to present my EHA talk to you in India. It's a pleasure for me because I actually worked in India 2 months back in the days during medical school in Pune. So for me, it's a nice way of coming back. So I greet you all, and I will start with my presentation. I will actually share my slides. Wait, that's the wrong thing. I think one.
You got muted.
You see my slides now?
Yeah, we can see your slide. We can hear you. Yeah.
Oh, okay, perfect. So I will talk about TPO-mimetics and aplastic anemia. And I'm from the University Hospital in Basel, where we have a history on aplastic anemia since the 70s, first for transplantation and then also for immunosuppression. And that's where I gained my experience from. Disclosures, I have a research support from Novartis, but otherwise I have nothing to disclose. To start with, we have to talk a little bit about TPO-mimetics. So TPO-mimetics, we all know from the setting of ITP, and thrombopoietin is the principal regulator actually for the platelet production by binding to the c-MPL receptor. And you can see this picture here on the left-hand side. It's actually from a review of the New England Journal for ITP back in the 2011. And it shows you quite nicely how those thrombopoietin-mimetics work. So you have romiplostim on one hand, which actually is given subcutaneously, as you might know, and it binds to the receptor at a different location than eltrombopac does. And that's important if we think about the effect in the end. So romiplostim actually binds competitively to the TPO binding site, whereas eltrombopac binds to the transmembrane region of the C-MPL, and it's taken orally. And both of them activate the JAK-STAT pathway. What is interesting is that this is not only working for the platelet production, they also stimulate in general hematopoietic stem cell and progenitor cells. And that is interesting, of course, in the setting of aplastic anemia, where you have a bone marrow failure and actually all cell lines are decreased. And that was the rationale in the end, actually, to test these compounds in the setting of aplastic anemia, although we have to keep in mind that in aplastic anemia, actually, the endogenous level of TPO is quite high. So in the beginning, everybody thought this is not a good idea actually to test this in aplastic anemia, but somehow it worked out. We will see the data in the following. So TPO-mimetics not only have an effect on hematopoietic stem cells, they also have potential other side effects. And I think it's really important to talk about those because we have an effect on that also in the clinics, and we should know about. So first of all, interestingly, it can increase regulatory T cells. You can see here that's on the left-hand side by this image. And by that, you can postulate it actually can induce some kind of tolerance, which is also important in the setting of acquired aplastic anemia, where we have an immune-mediated disease. What also has been shown that TPO-mimetics, and especially eltrombopac, can decrease interferon gamma and TNF-alpha release, which also plays a role in the immune modulation. At the end, and that's a very interesting study by the NIH, what could be shown actually that thrombopoietin plays a role in the setting of interferon gamma, and actually you can bypass the inhibitory effect of interferon gamma, which we all know of, on the hematopoietic stem cells by giving those compounds. So that's very interesting because we know that interferon gamma plays a significant role in the pathogenesis of aplastic anemia. And in the end, what has also been shown is a nice side effect in our patient is that it can actually cause iron chelation and depletion. And as we know, many of our patients are iron overloaded by many transfusions they get. So if we want to look at the first results in aplastic anemia, we have to look at the pivotal trial by the NIH, which was published in the New England Journal in 2012. And they tested eltrombopac, orally given, in refractory aplastic anemia. So that these were patients who were unresponsive to immunosuppressive treatment. And eltrombopac was given for 12 weeks, and it was given in a higher dosage than we know of in ITP, because they wanted to overcome the effect of the already increased level of TPO. So it was given at 150 milligrams maximum dosage. And what you can see here is that actually 44% of those patients responded. They responded not only in single lineage effect, so they responded in many patients also as a tri-lineage response. And you can see quite nicely here in this still small cohort that it has an effect in aplastic anemia. Although we have to say the effect is not rapid, so you have to wait more than you know of in ITP to see a response. Of course, if we think about the effect in refractory patients, we are also interested in the effect in the first line setting, and that was also published by the New England Journal, by the NIH in the New England Journal in 2017. It was a phase 1/2 trial, and it tested the compound in so-called 3 cohorts. So the patients were either given eltrombopag from day 14 to 6 months, that was the cohort 1, or eltrombopag from day 14 to 3 months, that was the cohort 2, or from day 1 to 6 months. And interesting, the cohorts were quite different in their response. So in the end, actually cohort 3, when you give eltrombopag from day 1 to 6 months, you could see the best overall response with 95%. That's huge if you compare it to historical controls, where the NIH, of course, has the data. And in the historical cohorts, the response overall was 66%. So you can see it has a huge impact actually in aplastic anemia in the first line setting together with cyclosporin and horse ATG. Now, everyone was very excited on the NIH results, but also, of course, wanted to see if this holds true for the randomized setting. And the EBMT, so the European Bone Marrow Transplantation Severe Aplastic Anemia Working Party, formed this trial. It's the so-called RACE trial. It was a randomized multi-center phase 3 study where eltrombopag was tested versus placebo. So it was either horse ATG and cyclosporin, or it was together combined with eltrombopag. And what you could see is that actually eltrombopag could be given 3 months from day 7. It was not given from day 1. That's a very important point if we keep in mind that the cohort 3 of the NIH with the best results, they gave eltrombopag from day 1. So that's one disadvantage of this trial, but this is actually due to the fact that the results of the NIH trial were not present when the trial was actually generated. So you could give eltrombopag for 3 months. If you reach this complete remission, you could stop eltrombopag. If you didn't receive a complete remission, only partial remission or non-response, you could continue eltrombopag for 6 months. But then eltrombopag had to be stopped, and standard treatment was actually given as otherwise already published. So you could give cyclosporin for 12 months full dosage and then had to taper it over a course of another 12 months, and then you had to stop. And if you had a relapse, you could reintroduce eltrombopag. So the results of this trial was actually published in the New England Journal just in this year, in January. And what you can see here is that group B, that is the group with eltrombopag, at 3 months actually had a higher complete response rate, so 22% versus 10%. What you can also see that after 6 months, and that's something we want to compare with the NIH data, of course, because they looked at also 6 months, is that the overall response rate was 68%. Now, if you think about the NIH data, it was much higher in the NIH cohort 3 group, and you could speculate why this was. And one reason is, first of all, eltrombopag was not given from day 1 in this cohort in the RACE trial, and second of all, the definition of partial response was done differently in a RACE trial. So PR was defined as transfusion independent, and that is the different to the NIH group. So you have to keep that in mind. Now, what was also looked at was the outcome data after 2 years, and this RACE trial included 285 patients. And if you look at the data after 2 years, you can see actually that still in group B, where eltrombopag was added, you had about 40% of patients who had either no response, a relapse, clonal evolution at 2 years. So you have still a high percentage of patients actually who are not sufficiently treated and are at need for further treatment. So I think it is not the complete solution for aplastic anemia. It has a huge benefit on achieving a quick response. I think this is very important because if we think about our patients, especially very severe and severe plastic anemia, especially in the first months after ATG and cyclosporin, as you might know, the patients are still transfusion dependent and are at high risk for infection and bleeding. And if you can increase the response in this time frame, you can actually have a huge impact on outcome, complications, and quality of life. So it has an impact, but in the long term, it still misses out on some points, and most likely we will need further management strategies for that. Now, if you look at L-Thrombopac in a different setting, so if we look at L-Thrombopac in moderate aplastic anemia, because the trials I just talked about were all trials were including patients with severe or very severe plastic anemia. So this is different. Now we look at patients with moderate aplastic anemia, and this is also a trial which was done by the NIH. They gave Thrombopac for 16 bis 20 till 20 weeks in this cohort, and they could achieve a response in about 50% of patients. You have to keep in mind that this was done as a monotherapy, so it was not combined with cyclosporin. This is also an interesting strategy. I will come to that, but this was not done here. So it is a monotherapy with L-Thrombopac, and it seems to have an effect, at least in 50% of patients. And what is also important, it doesn't increase the rate of abnormal cytogenetics, so clonal evolution, where we always were worried about with L-Thrombopac. So that doesn't seem to be the case. And it had also no impact on somatic cancer gene mutations. So that's good. What we have to keep in mind, and I think that also holds true for India, is that moderate aplastic anemia might also include inherited disease. There are several inherited syndromes which can cause bone marrow failure, as you know. And often those syndromes actually present with a moderate aplastic anemia, not with a severe or very severe aplastic anemia. And that's something which also was shown here. Also in this cohort, they had patients with germline mutations. So it might be inherited disease, but still in this small group of patients, there were 2 patients in this cohort, they could see an effect regarding L-Thrombopac. And there are currently studies ongoing where they test L-Thrombopac also inherited disease, but that's not topic of my talk today. So moderate aplastic anemia is a very interesting field, and the European Bone Marrow Transplantation Society, and in particular severe aplastic anemia working party, is also performing a study for this patient group. It's called the EMA trial, and it is testing L-Thrombopac together with cyclosporin. And I think that's a very interesting strategy because acquired aplastic anemia is and this is the study population for this trial, also immune mediated in several cases. And if you can add immunosuppressive treatment with cyclosporin, you might achieve a higher effect than giving L-Thrombopac alone. So this is interesting, but it's still ongoing. And then I will also want to touch upon shortly on pediatric aplastemia, but I do have to say I am not a pediatrician. I'm an adult hematologist, so this is not my specialty. But just looking at the data in the literature, and there's one prominent paper on that from the NIH as well, where they tested L-Thrombopac together with HORT-ATG and cyclosporin for 3 or 6 months and compared this to historical data. And they could actually see no difference in overall response. So this was a negative study. There is another study from Russia, which doesn't show a big difference as well. And there is one study from the US where they might show a response and effect, but in the end, right now, what I hear from the pediatric community, L-Thrombopac does not play a role in this patient population. And actually in young patients, if you have a matched-related sibling donor, you should go for transplantation. And then regarding long-term effects, because this is of course a very important topic, and everyone was worried about that L-Trombopac can induce clonal evolution, and it might have an effect on that in the refractory setting. Because what you can see is that in the refractory setting, at least in the NIH cohort, you could see abnormal karyotypes in about 19%. What is important and helpful for the clinics is that those clonal evolution cases were actually occurring in the first 6 months after EPAC start. And this is something which we can easily monitor as a clinician, because we should do bone marrow puncture actually. We should do bone marrow puncture after 3, after 6, and after 12 months. And by that, we can actually detect clonal evolution more easily. We could also see, and this was of course analyzed in the first line setting as well, that clonal evolution was an issue, but it was not increased in comparison to historical controls. You can see here this on the right hand side. So in the first line setting, together with EPAC and ATG and cyclosporin, clonal evolution occurred about in 15% of patients. And this is from the NIH with a follow-up of 4 years and a patient population of 178. So I think it's a quite solid data to learn from. And also, as I already touched upon in the refractory setting, and is helpful for the clinic, clonal evolution is not increased in its rate, but it occurs earlier. So in comparison to the historical data, it occurs at about 186 days, so also in the first year, versus in the historical controls after 770 days, so much later. So also here, surveillance bone marrow puncture is important to screen for clonal evolution. If we look at relapse rate, I touched upon this already a little bit in the RAISE trial. We can see that actually in the end, also 40% of patients relapse. And what we can learn from the NIH data, that these relapses occur at specific time points. So for example, if you lower cyclosporin and you stop L-Trombopac after 6 months, there's a group of patients who will relapse. We already know this from cyclosporin many years, that cyclosporin, if you taper and if you stop, patient will relapse, at least some of them, and some of them will need long-term maintenance. But this is also the case for L-Trombopac. So if you taper or at least stop L-Trombopac, you will have some relapses. What we actually started to do, and many centers in the Europe also do this, they don't stop L-Trombopac from one day after another anymore, although this was done in the trials, but we also taper L-Trombopac nowadays. Now, in the end, I want to have a quick word on romiplostim. Romiplostim is the other compound of the TPO-mimetic. It is given subcutaneously and also is interesting in the field of aplastic anemia. And we have here some phase 2/3 results in the refractory setting, where you could see that if you actually use romiplostim and titrate it over several weeks, you can actually achieve, in this at least sub cohort, 84% of hematological response after 27 weeks. So it seems to have a high effect actually, but this has to be proven by other studies as well. I think it's too early to trust this data, but it's definitely an option. And of course, it's also very interesting in the first line setting, and that was also presented at the AHA 2022. With that, I want to come to the end and summarize a little bit of what I have talked about. So if we want to look at acquired aplastic anemia, we should always in the beginning look at the severity of the disease. So if you have severe or very severe aplastic anemia, and if you have a match-related donor and you are young, you of course are a transplant candidate. And for that, the data is very solid. So L-Trombopac does not play a role in this group of patients. If you are older and you don't have a match-related donor, then the setting is different, and immunosuppressive treatment is playing a very important role. And I think right now the data is very solid, and it is the standard treatment right now to use L-Thrombopac together with immunosuppressive treatment as a first-line treatment in very severe and sideroblastic anemia. You can see this here on the left-hand side, the data from the RACE trial and from the NIH group. So this is the standard. If romiplostim is also useful, we will see. In the refractory setting, I think EPAC mono is an option. I think some centers also give EPAC together with cyclosporine, but we don't have the data on that actually yet. But I think otherwise it is quite solid as well that you can use EPAC monotherapy, and especially I think in patients who are older and where transplant doesn't play a role, this is a good option. Then in moderate aplastic anemia, we have data from the NIH that it is helping and working out, but we should be, and we are very excited if we can improve this response by adding cyclosporine. So we will have to see what the EMA trial does. And in pediatric aplastic anemia, I think EPAC right now doesn't play a role. So with that, I want to conclude my talk. I thank you very much for the invitation, and I'm very open for questions. Thank you very much.
Thank you so much, Dr. Drexler, for beautifully reviewing everything that was available on this front. So we have some questions to you. Dr. Rajat.
Sorry, yeah. Oh, fantastic talk. Thank you so much. I'm a pediatric hematologist. I have one question and just one comment to make. The question is, a few days ago, a colleague of mine had a moderate severe aplastic anemia in a 12-year-old kid who is negative for all the investigations and things. She found out a paper of using single agent L-Thrombopac, which I was not aware of. So listening to your talk, it's not an advisable treatment. And if we need to use it, probably you'd use a cyclosporine with it. Is that what I gather from your talk? So that's the one question. And second, a comment I want to make, the pediatric hematology group, I think, has completely moved to a transplant. So there's, whether you have a match sibling donor or not, actually doesn't matter. We are doing nowadays upfront haplotransplant, and it's actually very good. If you do it early, actually the results are fantastic. So that's what I want to say. Thank you.
Yes, absolutely right. So I just had a meeting today with other pediatric colleagues, and they're doing the same thing. So it is this upfront transplant is currently the standard, I think, for the pediatric patient population. So for I think the first question you had was for a moderate aplastic anemia patient. Is that correct? Did I understand that right? Yeah. I mean, yeah, I'm not a pediatrician. I think for moderate aplastic anemia, you should really be careful for looking for inherited disease. And inherited disease is very tricky to find in some cases, because they not always have to have morphological issues or family history. Sometimes it's very cryptic. And the genetic testing is also sometimes very difficult, because you can find variants of unknown significance, and then you are not sure if it's really pathogenic mutations or etc. So that's a huge field where we have to learn immensely in the future. But right now, I think if you're sure it's an acquired aplastic anemia and moderate, I think the data for now are not solid enough to use L-Thrombopac in this setting. I would stick to cyclosporine or what is available in your country. Yeah.
Okay, thank you.
Thank you. And we'll go to Dr. Jagdish Chandra.
Good evening. That was a very comprehensive talk on the use of L-Thrombopac and romiplostim in aplastic anemia. As you have shown, the L-Thrombopac has gone from being used in the refractory cases and getting trilineal response, though it was expected to give, say, rise in the platelet counts, and then being used upfront. Your presentation showed that the response rate in adults is to the tune of overall response rate to the tune of 90% or even above that. And on the other hand, there is clonal evolution, that too occurring within the first year and to the tune of 19-20%. So is this clonal evolution leading to any clinical effects, and what are those clinical effects that this has? Thank you.
Clonal evolution, thank you very much for this question. Clonal evolution is a pot, I would say, with several forms of clonal evolution, right? So clonal evolution is sometimes also defined differently regarding on the publication. But what I understand on clonal evolution is, first of all, either like a myeloid malignancy, so AML or MDS, as we know, which can happen in aplastic anemia. So that's for sure clonal evolution. Clonal evolution can also be that you have a cytogenetic aberration like monosomy 7, for example, which puts you at high risk for then transforming into AML and MDS. That's also clonal evolution. So that's why we should always do a FISH or at least other conventional cytogenetic analysis if we do bone marrow puncture. And I don't know if that's always available at every center, but at least in our center, we try to do a FISH in doing bone marrow puncture. And then there's this huge field where not everything is clear yet when we look for sequencing data. So nowadays, of course, we also look for somatic mutations, and this is not sure if we can talk about clonal evolution in that sense, because somatic mutation, as you know, it can also be a chip, or it's not clear if this is actually disease. So we should be very careful on that. I think if you have a TP53 mutation, then it's a clear clonal evolution. But otherwise, I think many of those mutations can be observed over many, many years and don't harm the patients. And we analyzed the data within the RACE trial, and what we could see is very interesting. So you have a very low allele burden in the beginning in aplastic anemia, and a cohort actually showed that over 60% had somatic mutations, and they increased over time. So if you look at bone marrow puncture after 6 months, for example, and later on, you could see that the allele frequency of those mutations and the frequency per se of those mutations increased. We don't understand yet what this means, if this really ends in disease or relapse or transformation or whatever, but it is an issue and we should be careful on that. So right now there's no recommendation to actually do sequencing on a regular basis. We do this within research, but not on a clinical routine basis. Does this answer a little bit your question?
Yeah, sure. Yeah, thank you.
Yeah.
Thank you. Dr. Shailendra?
Thank you, ma'am, for this nice talk. Just wanted to know that you mentioned after 6 months of using L-Trombopac, then the study says only 6 months, and you said that you also taper in your clinical practice because continuing indefinitely is not possible. So what is your tapering strategy for L-Trombopac in your patient?
Yes, so we actually are tapering L-Trombopac. We don't stop from one day of another. You have 150 milligrams, so you can taper 25 milligram every month, for example. That's what you could do. You can also say you taper every 3 months. That's another different strategy, and you can reduce, for example, by 75 milligrams. I personally are a little bit more careful. Also, in particular, I'm also very careful regarding cyclosporin. I taper it monthly, and I taper, for example, cyclosporin, I taper like 10% per month, not more. And L-Trombopac, I taper by 25 milligrams because that's the tablet dose. There's not much to play with. So that's how I do it. If I have a patient who is still in complete remission, then I do this. If drop a platelet and other blood values are dropping, then you have to be careful. Then you can wait a little bit, and then if it's still stable, you can start taper and continue. Yeah.
And a second question, in your clinical practice, like how you monitor for clonal evolution? Is there like some clinical indication if your patient had a response and then now he's losing response and then you do it, or you do it routinely on annual or maybe?
So we actually do it routinely after 3, 6, and 12 months. That's like a fixed time point for every aplastic anemia patient after ATG, cyclosporin, and Eltrombopac. And I think with that, you have a very good setting to actually detect clonal evolution, because as I showed you, clonal evolution nowadays occurs early. And later on, we only do bone marrow puncture if we have sign for relapse and blood values drop.
Thank you.
Thank you. And if you see these changes, do you then immediately stop Eltrombopac?
You mean if we see clonal evolution?
Yeah.
Well, I think if you see clonal evolution, you have to think about a second-line treatment. And the most popular second-line treatment is setting is transplantation. So you then stop Eltrombopac, yes.
Sure. Dr. Chandran.
Thank you very much for a very nice talk. My question is slightly off topic. So you were mentioning about the thrombopoietin mimetics mechanism, especially improvement in T regulatory cells and inhibition of TNF alpha and gamma interferon. So do you see any prospect of like these drugs coming into GVHD prevention or treatment of GVHD in the case of transplant setting?
Good question. Yeah, that's very interesting, actually. I don't know of any data on that. I mean, we have now ruxolitinib, which is working on that, and that's now in the clinics, and we use that very regularly. But with Beverley, I have actually, or Eltrombopac, I don't know anything on that. What I do know is that, for example, the NIH now is testing ruxolitinib in aplastic anemia. So the other case around. Now we take the GVHD treatment for aplastic anemia. That's what I know of right now.
Thank you very much.
Dr. Siddharth.
Yeah. Good evening. Thank you. It was a really nice lecture. I just have a patient of 68-year-old male, severe aplastic anemia, who didn't respond with ATG and HOTS ATG and cyclosporin. And later, I started with danazol, and patient responded partial response and maintained. And then I stopped danazol, and patient maintained the response for almost 2 years. And now patient relapsed, and now I have started danazol, but there is no response. So what could be? And patient is not fit for transplant. So what can we do? What is your suggestion?
Yeah, that's an interesting case because we are not using danazol too much in our center. We use danazol for the telomere disease, but otherwise in aplastic anemia patients, like acquired aplastic anemia, we don't use this compound. But I know that many of you outside do. Right now for this case, I think if you can get Eltrombopac, this could be a good option together, for example, with cyclosporin. I would combine it with cyclosporin. I think that's a decent therapy to do so.
Is there any data for Eltrombopac, cyclosporin, and danazol?
No. There's no data. There's not even data with cyclosporin. There's only data for Eltrombopac monotherapy in refractory patients. But I would feel confident to use also cyclosporin.
No, is actually creatinine is 1.9. So cyclosporin I was a little bit hesitant to use. That is another thing.
Yeah, okay, I understand. Then you could think, yeah, I mean, some centers also use sirolimus, for example, if you have a kidney problem. There is not too much data around with sirolimus and aplastic anemia, but there's also a possible way to do. Yeah.
Thank you. Dr. Rajat. Yeah, thank you. Dr. Rajat. Are you there, Dr. Rajat?
Sorry, I had already asked my question.
Thank you, Dr. Rajat.
Thank you, ma'am. That was a lovely presentation. My question is, in a case of relapsed aplastic anemia, like a case which should have relapsed like 1.5 or 2 years after the immunosuppressive therapy, there was a time when we used to use a repeat rapid ATG as a salvage therapy. So now that Eltrombopac is ruling the aplastic anemia, so where do we place this repeat rapid ATG?
I can just say what we do, and we don't use rabbit ATG anymore for aplastic anemia. We stick to horse ATG, nothing else.
The first line is horse ATG, but when the case relapses, so we
Same.
consider rabbit ATG, right, ma'am?
Yeah, but we stick to horse. We don't switch.
So if we have the option of a repeat ATG versus Eltrombopag, what would be the preferred one in a case of relapsed aplastic anemia?
I think in relapse, you should always, you should always screen if the patient was transplant eligible, because I think that's the best option you have. If is not transplant eligible or you have no donor, I think right now you should then repeat immunosuppressive treatment, or you can switch to Campath. That's another option some centers do as a second line treatment. But for now, I think there's not too much robust data that the switch from horse to rabbit is helping on too much, for example.
So Eltrombopag is a therapy for a relapsed aplastic anemia, right, ma'am?
Oh, yes. Right now, I only use ATG cyclosporin together with Eltrombopag. I'm sorry if I didn't point out that correctly. Yeah.
Sure. Thank you, ma'am. Thanks.
Krishna?
Do you screen for telomere disease for every case of aplastic anemia? And if you find any problem with the telomere length, how do you act upon it? Will Eltrombopag work in those cases?
That's a very good question. So we have the problem, and I'm open on that, how this works in India, but we don't get the results on telomere lengths very quickly, actually. So it takes several weeks till we have the results on the telomere lengths, and in those weeks we already have to start treatment. So that's a difficulty, and we that stick to the clinics. I mean, we have to, if we have other signs for acquired aplastic anemia, for example, if you have a PNH clone, then it's more likely that the disease immune mediated, then we stick to the classical treatment of acquired aplastic anemia. So right now we cannot adapt our treatment to telomere length. I think there is no data around on telomere length in Eltrombopag and immunosuppressive treatment. That's something which is open.
Thank you.
Thank you. Prashant?
Hello, ma'am. It was a nice presentation. Sorry, I'm going back to the clonal evolution again. I just want to know, these clonal evolutions, did they happen in patients who really completely responded and went into a CR, or it happened more in patients who did not respond to the treatment and then developed a clonal evolution?
For that, I would have to look at the raw data, so I can't answer this really precisely. What I can say from our experience is that usually patients who have only a partial response are at risk, of course, in a higher percentage. But we also had patients who had a complete response and after several years then had this event. So I cannot say for sure. And what I do know is that the NIH actually looked at risk predictors for clonal evolution, and they could see that patients who have a higher neutrophil count, for example, and are older at first-line therapy are higher risk for that. Yeah.
Okay. Thank you, ma'am. One more just question. This is little off the subject. In ITP patients, when we use Eltrombopag, a lot of the patients, they respond well, and along with the platelet, even the hemoglobin starts jumping up.
Mm.
So in that kind of a case, do you have a strategy to cut down on the Eltrombopag dose or do a venesection on these patients?
I'm not an expert on ITP, I have to say. That's not something I nowadays treat too much, so I cannot give you the perfect answer on that, I have to say. So that's something I have to say you have to address to an ITP expert.
Okay, thank you,
Dr. Drexler, with respect to this clonal evolution, Do you do the baseline conventional cytogenetics and FISH on your patients now?
Yes. Yeah. Conventional cytogenetics is not always possible at diagnosis because you have an aplastic bone marrow, but FISH is possible. And then further on, you also can do conventional cytogenetics. Yes.
So
we do.
That as a baseline for everybody?
Yes. And
is that a predictor for evolution?
Not that I know of, actually. No.
Right.
Yeah.
Dr. Sanjeev.
It's used to differentiate to MDS, right? So it is still a very important result.
Right. Dr. Sanjeev. You are muted, Dr. Sanjeev.
Good afternoon, ma'am. My question is, any pediatric working group has shown positive data with L-thrombopac, or what may be the possible explanation for not working in pediatric group?
So the speculation is that in pediatric patients, the stem cell population is still not completely depleted. So that's the reason why actually L-thrombopac might not be that effective as this is an adult patient. And I think for this, the data shows no significant difference if you look at the NIH data or also the Russian data. That seems to be the strategy or the thoughts on that. Yeah.
Thank you.
Thank you. Dr. Priyanka.
Thank you, sir. Thank you, ma'am. My question is about the PNH subset of aplastic anemia, because presently the treatment of PNH is out of pocket for most of our patients in India right now. Is there any data regarding these drugs in PNH subset?
There's not a study which is looking in particular on PNH aplastic anemia overlap patients. But of course, we have patients in the cohort who have PNH clones. Usually those clones are small. And in the beginning, there was some worries that those clones can increase over time, but this couldn't be confirmed in both trials. So actually PNH was not increasingly seen with higher clones by using L-thrombopac. But still, patients with aplastic anemia are at risk to show clone evolution into PNH overlap or to increase their clone size. And in the end, some of them need therapy if they can get so.
Thank you.
Thank you. Dr. Chirag.
Yes, good evening. In relapsed aplastic anemia, where you are using L-thrombopac, how long to wait? Because some patients take apparently long time to respond. And anyway, there are not many options. And in long run, say, we have somebody with a no response, then how long to wait? And if somebody has a very minimal response, but just became transfusion independent, now how long to continue for them before you say that now you have had enough of this drug? And thirdly, if any role of switching in these patients from L-thrombopac to romiplostim to improve the response further?
Usually you should see a response after 3 to 6 months. And for longer, I wouldn't use the drug if you have no response. Then you should either go for transplant or other second line treatment, because the patients are at high risk for infection and bleeding.
And for people with partial response, how long do you continue? The original studies were that 2 years, so not sure how in the real life, how long to.
That's a big discussion in the community. So some physicians say with partial response, you can already consider transplantation. but I think you really have to differentiate between what form of partial response you have. So there are those patients with a poor partial response, I would call them, where you have like a platelet count of, let's say, to 40 to 50, and you have maybe still a transfusion dependency with, then those patients, of course, I mean, from the long term, I think you're not on the right track. But if you have like a partial response with platelet of 90 and transfusion independency, I think this can work for several years quite well with good quality of life. And then the discussion when to perform transplant is very difficult. And many of my patients, at least, they don't want to be transplanted in this setting. So that's difficult. But what we have to keep in mind is that many of those patients will need long-term treatment with cyclosporin and Eltrombopac, and I think the data is not made yet how long-term effects with those treatments are. We have data of, for 4 years right now. That's the follow-up time we have, and right now this seems to be safe, but for longer we don't know yet. And of course, cyclosporin, as all you know, can cause renal dysfunction, etc. So it's not a treatment you want to do for many decades, but of course some of those patients will need this treatment for decades. So it's a difficult question and has to be done individual with the patient and what his thoughts on this are.
And should we be doing bone marrows in these people for clonal evolution?
I think if you have a significant drop in blood counts and you're not changing therapy in this setting, then you should look for a clonal evolution, yes.
Thank you, Chirag. Amit?
Yeah, ma'am, I have a case actually of 42 years male who had known A, known B, known C, chronic liver disease, for which he undergot liver transplant. And after liver transplant, he lands up into severe aplastic anemia. Now, for that, the patient was started on ATG and cyclosporin, but no response after even 8 months of this ATG cyclosporin. The liver transplanters say we cannot give any other treatment. What is your thought whether post liver transplant can we go for TPO-mimetics, Eltrombopac, or romiplostin in such patients?
That's a tricky case. How old is the patient?
He's 42 years.
I think if he has no response to first-line ATG cyclosporin, then it's a transplant candidate with that age. Otherwise, I think Eltrombopac in this setting, there's no data around. That's difficult. To
because just 20%
support
of Eltrombopac lands him into hepatotoxicity. So whether romiplostin right.
Thank you, Amit. Dr. Amrita?
Dr. Drexler, that was a wonderful presentation. So 2 questions I had. First is, well, how safe is it giving CSA or TPO receptor agonists in cases of pregnancy? We know that pregnant patients tend to relapse. Aplastic anemia tends to relapse in such patients. So is supportive care the only therapy, or would you prefer to give CSA in such patients?
Right now, there's no data around to use TPO-mimetics in pregnancy. So I wouldn't use TPO-mimetics in pregnancy. Maybe there are some random cases in the setting of ITP I don't know of. Most likely there are, because pregnancy can happen very randomly. And many ITP patients are young and use Eltrombopac, so maybe you can find some data on that. But for the aplastic anemia population, right now, this is not an option. I would use cyclosporin. Is allowed, right. Yeah.
Okay. The second question is a little, well, out of the line. What we know from the guidelines, the BSH guidelines, is that vaccination in general should be avoided in patients who are have aplastic anemia, being treated and now in remission, including influenza vaccines. So now in the COVID era, would you recommend COVID vaccines or in treated patients of aplastic anemia?
Yes, we fully recommend vaccination for COVID in aplastic anemia patients. Many patients are afraid of relapse, and there have been some case reports on that relapse can occur. But right now we are also gathering all the data from the European community to really show if this holds true, if these case reports are comparable, and we don't have the data yet. But there is a group, the German group, actually, they have also the NIH actually have set their recommendations on that, and they all confirm to vaccinate this patient population because the benefit is higher than the disadvantage.
Right. Thank you.
Thank you, Dr. Amrita. Dr. Drexler, we will just take you another 2 minutes. Few questions lying in the chat box. Is there any data on combining eltrombopag with romiplastim?
Not that I know of.
Right. Other question is, if a patient relapses 2 years after use of eltrombopag and cyclosporin, can you reuse these?
Yes.
You can.
Yes. Yeah.
Those were the couple of questions in the chat box. So thank you very much, Dr. Drexler. This was a very long question answer session. And after your talk, people were very stimulated to ask you all these questions. Thank you so much. Grateful to you for sparing your time and educating people. We have participation from 25 countries today. So they have heard you today, and I think this will be a big impact on their practice. Thank you.
Well, thank you very much for the invitation. It was an honor for me to talk to you, and I hope you have a good education session coming up too.
Thank you. How long were you there in Pune?
2 months. I lived 2 months in Pune. Yes, working in the hospital. Yeah, I think it was in 2007.
Okay, long ago. Okay.
Yeah, long ago. And afterwards, I traveled 2 months. So 4 months of India. Yeah.
Traveled all over?
Oh, I traveled to Delhi, of course, the triangle. So Jaipur, Jaisalmer. I also visited Shimla, Dharamsala, Kerala in the end. And I came back and I went to Varanasi and to Bangalore.
Wow.
Yes.
So many names.
So I do have an attachment to India. Not now, and because I can't travel too much anymore with family, but back in the days, yes.
Thank you so much. Probably you have traveled more of India than many Indians. Thank you.
That's what some Indians say, yeah. So I'm very, very happy I could do so. Thank you very much.
Thank you. Bye-bye.
Thank you.
Bye-bye.
So we will move to the last lecture of the day, and that is by Dr. Linda Larsson from Sweden. And she is from the Department of Clinical Immunology and Transfusion Medicine, Karolinska University Hospital, Huddinge, Stockholm, Sweden. And she's going to speak to us on blood components, what is in the bag, and can we make a better and safer product? So over to Dr. Linda. Yeah.
Hello, everyone. Just gonna see if I can show my share my screen, but it's not starting very well because I'm pressing the wrong button. Let me see. Am I sharing my screen now? Do you see my presentation?
Not yet.
Not yet? Okay. Why is that? Okay, wait, sorry.
Yes.
How about now?
Yes.
Is it working?
It's working.
Okay, fantastic. Thank you very much. Thank you for
slideshow mode.
Is it not in slideshow yet?
Not yet.
Why is this not working? Okay. New share. Okay, wait, here I've got it, I think. And now?
Not yet. Yeah, yes. Now, yes.
Is it? Brilliant.
Yeah,
Please
yeah.
let me know if something is not working when I'm changing pages or whatever.
Sure.
I think it probably takes some a while for the connection to travel all the way from Sweden to India, I imagine. Anyway, very happy to be here today. Thank you for this kind introduction and thank you for inviting me. I was asked to talk about blood components and try to answer the questions, what is in the bag and can we make a better and safer product? I have no conflicts of interest to disclose. And the first question is very simple in a way. What is in the bag of red cell concentrate? Let's start there because it seems from the beginning, it seems easy to answer, right? We got the red blood cells around 150 to 200 milliliters. And we got some additive solution. The additive solution is there for several reasons. It's there to prevent coagulation and it's there to provide nutrients such as glucose and ATP building blocks for the cells. And it's also there to protect the cell membrane. Basically, to make the red cells feel happy for as long as possible, even though they are not stored in the body anymore. The red cell concentrate also contains a bit of plasma, not much, around 10-15 milliliters perhaps. And this is because it's not possible to separate whole blood completely. If we do that, we would need to actually centrifuge the bag so hard that we would break all the cells, and that's not really what we are after. So we have a bit of residual plasma left. We also have a bit of leukocytes left. Of course, they are reduced if we do leukofiltration or get the cells from apheresis technology, but there's still some leukocytes left. With leukofiltration, it's about maximum 1 million. And it sounds a lot, but it really isn't. And the reason we reduce the leukocytes or try to get rid of the leukocytes is that there's no benefit of them. They're just considered garbage in this respect. And with time, the red cell concentrate also contains increasing levels of red cell debris from the metabolism, such as increasing amounts of free hemoglobin and iron ions and free potassium ions, and also pro-inflammatory membrane vesicles. And if you are very unlucky, it could also contain blood-borne pathogens, such as virus, bacteria, parasites, etc. And this is mainly if the routines for donor selection or donation or processing were not followed accurately. So how do these different categories affect the red cells, and how can we use our knowledge to improve the overall patient safety? Well, you need to know your component. The contents of the bag depends on, first of all, like the red blood cells actually are different too, because they depend on the donors. They're related to which donor we had, but we can't do so much about that. The additive solution actually affects the red cells because the choice of additive solution, it affects the red cell quality and the maximum time we can store them after collection. And the plasma in the bag, it's actually good to have some plasma left in general, because it does provide some buffering capacity for the red cells, which I'm going to talk about later is beneficial. But for some patients, it's better to remove all the plasma than to keep it. And the leukocytes, if you remove leukocytes, you have less hemolysis and also less transfusion-related complications. And it can, on top of this, also be very beneficial for some patients if we inactivate the leukocytes, they can't proliferate anymore. The levels that we have in the bag of red cell debris, they affect how the red cells are. They affect the red cell quality and the maximum time that you can store the red cells. And this can cause some harm if these levels are too high. And also, obviously, pathogens can cause harm. But the good thing is that they're avoidable with good routines. And also, you can apply pathogen inactivation to increase the safety. So in other words, the contents of the bag depend on, first, the donor characteristics, who the red cells come from. And the processing strategy you use when you separate the whole blood into red cells and components, meaning how the red cells are recovered from whole blood. And the storage conditions, how the bag is stored in terms of temperature, position of the bag, movement, and also time, how long the bag is stored. both before processing and after processing. And actually also the container, the bag plastics and the plasticizer used, what kind of bag the cells are stored in. And as I said, also hygiene or routines for donor selection, answering questions such as did bacteria have a chance to get in, or were viruses or parasites passed on from the donor. I'm going to have a very brief crash course in red cell biology. Red cells, they use glucose as their only source of energy. They don't have any mitochondria, so there is no citric acid cycle that can generate a lot of ATP. So the red cells depend completely on the breakdown of glucose into lactate to generate ATP. And in this process, proteins are also generated. And both lactate and the proteins are acidic. So when these accumulate with storage time, pH decreases. And if pH decreases, in the sour environment, the breakdown of glucose is slowed down. The whole glycolysis goes slower. And by there, less ATP is generated. And why is this bad? Well, it's bad because the less ATP we have that the red cells generate, we get changes over time, metabolic, morphological, oxidative changes that are called a storage lesion. And the effects of these storage lesion changes are several, and they're not very beneficial at all. First of all, we get hemolysis, meaning the cell ruptures. This is the final stage of the red cell metabolism, but also in a way the most important one, because if the cells rupture, obviously, first of all, there's a function loss. If it's broken, it can't transport oxygen anymore. But also when this ruptures, free hemoglobin and iron ions are emitted out of the cells, and you can actually get an iron overload by this, or the iron ions cause free radicals to increase, and they can also stimulate bacterial growth in a concentrate. And there is also an accumulation of potassium ions, both because of this cell rupture, but also before that, when ATP starts decreasing in the cell, the pump in the cell membrane pump that regulates the potassium and sodium balance, it doesn't work as well anymore. So more potassium is accumulated outside of the bag. And if you transfuse a bag that has really high levels of potassium, there have been cases where this has induced arrhythmia or cardiac arrest in the patient. And also, there is a loss of cell membrane, meaning the red cells, when they don't have ATP any longer, so like with storage time, they start getting uneven. They start getting sort of spiculas, which has the tops of the spiculas are emitted into so-called microvesicles. And these in turn, it's debated, but most evidence suggests that these have pro-inflammatory effects. But also what is left after when these microvesicles are emitted, it's very dense and rigid round red cells, and they can't bend anymore. So when they get to a capillary, it can cause occlusion there because they can't get in anymore. Like like a young red cell that can like bend to really get into all these really small passages. And also, it's been shown that if you have too little ATP, there's decreased post-transfusion survival of the red cells in the patient. So you can't use them for as long as you think you can. And also with time, there is a decrease in 2,3-D phosphoglycerate, 2,3-DPG. And this is a compound that is involved in the oxygen unloading capacity. So if you don't have any 2,3-DPG left in the bag, it just holds on, the red cells just holds on to the oxygen and doesn't let go of it at the tissue. It just like keeps it close and takes it with you back again. And then you don't need this gas exchange. So it's also not very beneficial. So even if you transfuse cells, you don't get the effect you want from it. So I think you all would agree with me when I said that we want to keep the red cells happy for as long as possible. And how do we do that? Well, we need to slow down the storage lesion changes. And if we look first at the additive solution, how we can slow down changes, a simple answer is choose a good one. For instance, in Europe, we use the most common additive solution is called SAGAM, and we've used it for many years, even though we sort of know that there is a next generation additive solution called PAGSAM that is better than SAGAM from a storage lesion point of view. And it's shown that when red cells are stored in PAGSAM, the red cells maintain their integrity for longer time than with SAGAM. But I mean, natural question is, why are we still using SAGAM? And that is, of course, because changing an additive solution means a lot of validation and authorization work. And we have sort of concluded that we don't want to do that as long as we have good enough quality. But this might change, because in Europe, we are facing a transition to non-DHP blood bags. What is that? Well, there's an oncoming regulatory requirement that we need to change the blood bag plasticizer. I don't know if you know what a plasticizer is. It's the part of the plastic that makes the bag soft and makes it easy to handle. And a bag that doesn't have a plasticizer is very brittle, and you can break it very easily, and we don't want that to happen. So plasticizers are essential to be able to centrifuge or do things with just normal things with a blood bag, transport, whatever, without breaking it. But these regulatory changes are saying that we can't use DHP anymore, even though it's proven that it's superior for red cell storage. And it's also been proven that if you store red cells without DHP, the hemolysis is much higher, the cell rupture. But it will no longer be allowed for toxicity concerns, and therefore the need for new plasticizer. So it has been shown in studies that you can actually obtain an acceptable red cell quality if you use a different plasticizer paired with one of these next generation additive solutions. So since we're going to have to do a lot of validation work anyway now while changing plasticizer, we might as well change additive solution as well, which is really, really good from a storage lesion perspective. And just to show you very quickly here, the blue and the green are different plasticizers, and it doesn't really matter. If you look at the red color represents SAGAM additive solution, and the yellow represents PAGSM additive solution. And we see when we look at hemolysis, that regardless of which plasticizer we used, hemolysis is lower when we use PAGSM. We can also see that if we look at mean corpuscular volume of the cells, sort of how swollen the red cells are during storage, and we see that the swelling doesn't increase as much in PAGSM than with SAGAM. So really there is a difference between different additive solutions. We can also look at the plasma. First rule would be, don't wash away the plasma unless it's warranted for the patient's safety, because as I said, plasma actually helps in buffering the pH, and we want to keep the pH stable and high for as long as possible. It's going to sink in inevitably, but we want to prevent that for as long as possible. That said, if we need to wash away the plasma, which is indicated for some patients, don't keep the red cells stored without plasma for longer than necessary. It's better to actually wash a bag close to when you want to transfuse it than very long in advance. And I'm going to show you this. Washed red cells, washing is done to remove the residual plasma, or actually to remove any accumulated debris. You can wash a cell because you want to remove potassium as well. And this is done for patients who had previous allergic reactions to anything in the plasma, or if they have an IgA deficiency or are sensitive to, for instance, high levels of potassium ions. The indications are different in different countries, but you get all these benefits from doing it. And the pros of washing red cells is that you get a very efficient removal of the plasma and debris. But the cons is that when you expose the cells to this washing procedure, it's literally like washing your clothes. You put the bag of cells into a washing machine, and the red cells are tumbled, and there is new additive solution in the end. So they go through a lot. So they are exposed to mechanical stress in these procedures. So there is some membrane damage and cell breakage. So therefore, it's suggested that after you have washed the red cells, you should shorten the expiry date. And for us in Sweden, this is also different rules in different parts of the world, but we can get up to 28 days of reduction. And that's pretty much if you have a 40-day overall storage time from the beginning, you only have 14 days left. And if I go just show you quickly extracellular potassium, what it can look like before and after washing. The pink dots are the reference RBCs where we haven't done anything, but the green line here, we washed these concentrates at day 14 post collection, and you can see that potassium was washed away very efficiently. The levels went down to 0, but after that, if we look at potassium per milligram hemoglobin or per cell, actually it's the same. You see that it increases faster, and this indicates that there's been some damage in the membrane of the cells. So therefore, you shouldn't store them too long after you washed it, because then the levels could get really high. And also, if we look at hemolysis, if you look first on the left picture, comparing washing in green to reference in pink, you see that hemolysis directly after washing, it starts increasing much more. And also on the right side, we see that the end hemolysis, if we zoom in on day 42, it's almost twice as high as reference. So washing is good when you really need it, but the cells get damaged from it, so you shouldn't keep them stored for very long after washing them. Another way to slow down the storage lesion changes is looking at the leukocytes. First of all, like I said, leukoreduce. We get this, there is storage-related hemolysis if you keep the leukocytes, but also there's several benefits, lots of clinical benefits, like reducing the risk of febrile non-hemolytic transfusion reactions, or alloimmunization to HLA antigens, or exposure to cytomegalovirus. So there's a lot of benefits in leukoreducing the red cells. But again, just like with washed cells, you can irradiate the cells for extra. You should always leukoreduce, in my opinion. It's always a good safety step, and it's also fairly easy to do. It's a passive process. You don't have to add too much energy, and it's also fairly cheap compared to other extra processes. But you can also add irradiation to stop the leukocytes, the residual leukocytes from proliferating, and that's good in some when it's warranted for the patient's safety, but you don't do it unless it's needed. And also after radiation, don't keep the red cells stored for a very long time. And this is actually for the same purpose as for washed red cells. Irradiated red cells are given, as I said, it's done to prevent the residual leukocytes from proliferating, and this is done to reduce the risk of transfusion-associated graft-versus-host disease. And this is, of course, very important. If you have a patient who has a suppressed or inadequate immune system, for instance, neonatals where it's not yet fully developed, or at the stem cell transplantation, when you have suppressed the immune system, then it's really, really important to inactivate the few leukocytes that are left. So the pros of irradiating red cells is, of course, this significant reduction of the risk of acquiring graft-versus-host disease. But again, the cons is that there's a stress also from irradiation that causes membrane damage, actually even more than washed cells. So there's also a need to shorten the expiring date there, which is a safety measure to not to make sure that for instance, hemolysis and potassium doesn't skyrocket, but at the same time, it's not really good for the blood supply if you have to shorten the storage time, the expiring date for the cells. And if we add extracellular potassium to this graph, the purple line, we can see here that we irradiated these cells at day 14, and we can see that very soon after irradiation, potassium really increases fast. So again, do irradiation if it's needed. It's very good, but don't keep the irradiated cells for a long time afterwards, because then you can cause some other kind of damage instead. And if you look at hemolysis on the left side, you see that when I added irradiation, the purple, it's even higher than for washed. And also if you zoom in on day 42, we see that it's 0.58% as mean, which is almost 3 times as high as reference. What we can do more is to look at the increasing levels of red cell debris and ask, how is our processing method? And optimize our processing strategies, which really can reduce the storage lesion effects. And this is probably most interesting for people at blood establishments who work a lot with the different processing steps. Because if you process a whole blood into red cell concentrate, there are multiple ways of optimizing this process. And it's really important to find your optimization strategies, because you can really do a lot with the component quality just by changing a few of all these steps. Multiple parameters, but you can look at time, temperature, the mechanical stress the cells are exposed to, the procedure you have for filtration, the procedure you have for addition of additive solution, how you do your transport, etc. And it's actually even more important to have an optimized processing process where when you know that you will do secondary measures such as irradiation and washing afterwards, because then you will add even more cell stress to the cells. It's good to have happy cells from the beginning, so to say. And just a few examples here on what you can look at is that, for instance, the processing time. And make sure that you get the red cells into the refrigerator as soon as possible. This is what I always tell my staff at my blood establishment. I've even put a reminder with my angry face saying, get the cells into the refrigerator before you go for lunch. It sounds funny, but it really makes all the difference. And you can even consider, can we separate the whole blood on the collection day instead of keeping it overnight first and then start the processing, because it does make a difference. Because when you get the red cells into the refrigerator, you slow down the metabolism, which is what we're aiming for. Also, you can look at temperature. Again, it's actually the same thing. You want to lower the temperature as soon as possible for the red cells. So you can consider the same things. First of all, can we separate the whole blood? Is it possible for us on the collection day instead of waiting overnight? Or can we make sure that can we cool down the whole blood to room temperature directly after collection? I don't know if a few of you do that or not already, but there are these cooling plates that you can put the whole blood on that helps taking the temperature down to room temperature from 37 degrees in the patient what it was from the beginning, and in the donor. And this also has been shown that it really makes a difference if you help cooling on the way. And also, there's a lot of steps where you can consider the cell stress. So just asking yourself the question, are we doing all we can to avoid excess measures? You don't actually need to spin the cell hard as we do. Can we have introduce a more soft spin? Or are we shaking the bags too vigorously when we mix the red cells and the additive solution? Or are the breakaway cannulas broken correctly? Because if they aren't, if you break them incorrectly, there can be sharp edges. And then when you press the cells against them, they break. So that's also a very easy way to control your process. And then when we remove the leukocytes, can we filtrate the red cells instead of filtrating the whole blood in the beginning? This is possible if you use the method where Buffy coat is obtained. And this has also been shown that there is some difference. I think somehow filtration of only red cells is just softer to the cells than filtrating them when all components are involved. And also just look at your transports. Can we pack the red cells smarter when we send them to another hospital? So they don't like jump around in the bag if there's a road bump, so they aren't disturbed in that way. And that also, it sounds, I don't know, kind of funny almost, but I've firsthand experienced that this makes a difference. There's lots of ways that actually aren't that difficult, where you can improve your processing and by that really improve the storage lesion, or make sure the storage lesion is kept at bay for as long as possible. And finally, looking at the pathogens, this is not storage lesion, but anyway, I mean, it's a very important safety measure to ensure that you have good hygiene and donor selection routines so you don't get pathogens into your blood components. But you can also consider future implementation of pathogen inactivation technology for red cells to be extra sure, to add an extra layer of safety. And pathogen-reduced red cells, this is a method that you add a chemical and it cross-links to the DNA in anything that is in the red cell concentrate that has a nucleus, meaning that if there are any present pathogens or residual leukocytes, they are stopped from proliferating. And actually, I can't speak for all methods because they are up and coming. They aren't on the market yet, so I don't actually know what all companies are working on. But the one that I think is closest to market release, that the one that I've worked with, which is called Intercept, this also contains a washing step, just a centrifugation step that can actually remove plasma and debris that has accumulated. So pathogen-reduced red cells are good, first of all, to all patients to reduce the risk of transfusion-transmitted infectious diseases, but also it can be used instead of irradiation for patients that need that because it stops leukocytes from proliferating, and it can also be given to patients that need washed red cells instead of doing the washing procedure because it contains a washing step. So the pros with pathogen-reduced red cells is that there's sort of a 3-in-1 procedure. You get irradiation, you get washing, and you get an increased TTID safety. And also a really important pro is that there is no increased membrane damage shown. So there's no need to shorten the expiry date, which is of course very good for the blood supply. Cons is that it's not available on the market yet. We are still waiting for it. I don't work at the company, so I don't know when. I know a lot of studies are being done and they're looking good. I've been involved in some myself, so I think they will be out pretty soon. So, but obviously, as of now, it's still a con that it's not available yet. And also, I've seen that the washing procedure is not quite as efficient as other washing methods. So they still need some optimization. I don't think it's very difficult to fix, but it still needs to be done, like adjusting the centrifugation parameters or add an extra centrifugation step or something like that. And also this procedure, pathogen inactivation, takes longer time compared to the other washing and the radiation procedures. So you sort of need to rethink the workflow. It's not necessarily bad, but you need to put some energy into thinking about how you're working and how you will work differently so it fits. And if we add pathogen reduction to this graph that I think you know by now, this is the orange line, and you see pathogen reduction was done on day 2 here, very, very in the beginning of the storage time. That's why it's this very small side step, but then it actually keeps, potassium keeps increasing with the same speed as the reference units. It's actually a bit lower than the reference units all the way through storage. And also, if we look at hemolysis, we see that with pathogen reduction, again, the orange, the end storage, the end value is similar to reference. There isn't even a difference. Very, very small, but not statistically significant. So this is also very good to know that there was no increased cell stress. So to conclude, how we do to get a better and safer component is first of all to try to slow down the storage lesion changes, because there's a lot of optimization steps to choose between. I'm not saying you should do all of them. That could be a little too much burden, but if you're aware of what you can do, you should choose the ones that fit your organization best. And also use leukoreduction. That's good both for slowing down storage lesion changes and also general patient safety. And also irradiate and wash the red cells only for the patients who needs it. I mean, don't hesitate if it's indicated. It's a really good measure to do. Just again, it's good to actually transfuse these components as soon as possible after these interventions. And also, when it's available on the market, I think it's a good idea to consider pathogen inactivation of red cells, because there would be no need to reduce the expiry date also, and it helps improving the blood supply. And also, as you say, the storage lesion changes are not as bad as with other interventions. And finally, Europe will likely need to change the additive solution soon because of this oncoming ban for the DHP plasticizers. So likely there will be many interesting publications on this to follow and see what additive solutions that could be recommended that would be good for future blood storage. And that's it. Thank you very much for your kind attention, and I look forward to any questions.
Thank you so much, Dr. Linda. You really opened our eyes. So much has happened in this field and so much update. Fantastic. Thank you so much for educating us today. We have some of our colleagues who would like to ask you some questions. Dr. Venkatesan.
Yeah, Dr. Linda, that was wonderful lecture. You have covered each and every aspect of blood transfusion, the procedures which you do at the laboratory, at your blood bank, at blood center. So one thing I would like to ask is about the pathogen inactivation. So how do we envisage the future of pathogen inactivation? Will it take over the NAT and the TTA staining which we are doing as on date today?
Sorry, can you repeat, because it broke a little? You said pathogen inactivation. What was the exact question?
Yeah, what is the likely future of this pathogen inactivation technology? Because so far we are reading and answering in the exams only about this technology. So will it take over the NAT and the other TTA staining which we are using as on date today?
I think it depends between different countries. And just speaking from myself, from Sweden, I think it would be very big step before we can be allowed to use it instead of virus tests. I think it's a long way to go before it can prove to be so sure that we can have it instead. I mean, in theory, it's possible. It's actually also how these companies market it, that viruses will be unnecessary. But I think if I asked our regulatory authorities in Sweden, they will say absolutely no to that. So I think maybe in the future it's possible, but I still think it's a long way to go. But I think also it's an excellent complement to cover window periods, things like that, and things also unknown pathogens that we don't test for today, but they're up and coming, or that we maybe if something spreads very fast in the world and we don't have a test in our country today because we didn't think we would need it, but then we have something that could at least cover it in the meantime and make the blood component safer. So I think we should look at it as a complement. That's my idea, at least, if I try to guess what's going to happen in the future. Thank you. Did I answer, by the way?
Yeah, thanks. Thanks a lot.
Thanks.
Thank you. Dr. Amrita.
Good evening. That was such a wonderful lecture. So I have two questions. The first is, in cases of donors traveling from malaria endemic areas in Africa or say Central America, where there is prevalence of West Nile or Trypanosoma, what is your policy of deferring donation, like for how long? And do you routinely test all such patients for such pathogens?
Actually, it's not my donor deferral is not my specialty, I would say. So I think the other question, people who are better than me to answer that. Me personally, I would look into the blood guide and I would follow the recommendations there blindly, what they say, because they have experts group who have established criteria for this. So the guide to preparation, use and quality assurance blood components. So that's what I would go to.
Okay, so another thing, I'm not sure if this is very relevant, but what is your take on pre-deposit autologous blood donation? I guess Europe is moving out of this arena. They don't prefer pre-deposit autologous blood donations anymore, except for maybe patients having a high frequency antibody against a high frequency antigen or rare blood groups. But in your setting, how often do you recommend or you ask for a pre-deposit autologous blood donation before surgery?
Yeah. First of all, let me go back to your previous question, because I had to think while you spoke. Sorry. I think that if you introduce pathogen inactivation, probably these deferral criteria can be reduced. Maybe in the future there will be new approaches to looking at these deferral criteria, because if you can show that you have pathogen inactivation implemented, so I think it's a good complement in that too. For autologous blood, we don't use that much. Actually, I looked at these figures last week, but unfortunately I don't remember them. I would say we use it mainly when, for instance, for orthopedic patients, where you can plan the surgery and you know that there is no need to expose the patient for extra, because there's always a risk with blood transfusion, even if you apply any safety measure in the world, because it's not from the patient's own body. So in some cases where it's not, we consider either if it's a bigger risk for the patients to get a transfusion, or just if you can plan a surgery really well, you can maybe take 1 or 2 autologous bags and just give it back to the patient if needed after the surgery. But it's not used a lot at all.
I guess cell salvage is used more often in cases of orthopedic patients, because some of the hazards of transfusion do persist even in autologous blood donation, as in wrong blood in tube or wrong sampling.
Yeah.
Yeah.
Okay. That's also a good way to ensure that at least you have the right blood.
Okay, and like patients having an antibody against a high frequency antigen or very, very rare blood groups, for them, I guess I wasn't sure. This is something I really haven't found any data much on how often these autologous blood donations are used before a major surgery. When you're trying to do a surgical blood management. So I just had this question.
Yeah. I think it's a fine balance between, I mean, if the patient needs blood, maybe you need to sort of like consider the benefits of first actually removing blood from the patient and how that will affect the patient itself. I know that in some cases when we have had patients that has really, really rare antibodies, we have really hunted to find a sibling or something that has the same antigen composition or so instead, because the patient herself or himself have been too sick to donate blood. So it's a fine line. And also we try to also keep a stock of frozen red cells for this context. But I know sometimes you just need to take what you have. Sometimes it is better if, again, you can plan to get the patient to donate blood for him or herself, because it might be a problem with a blood type later. But it's a fine balance to not cause more harm by actually by autologous donation. I think it's a case-by-case decision.
Also, I'm so sorry for taking up your extra time. Just one quick question. In cases of IgA deficient patients with no reaction, no history of previous reaction to any blood products, do you still routinely go for washed blood products, or you just give normal leukodepleted products?
I think this also is different between different countries, but if the patient has had no previous reaction, you usually don't know that this is going to happen. And we don't test all the patients for IgA deficiency. So it's sort of a learning by the first time you get a reaction, and then making sure that the next time we know this about this patient and we will wash the blood further on. So it's unfortunately, I mean, that's how you realize sometimes, because there was a reaction. In the
So
ideal
just,
world, you would test everything beforehand, but we also know it's not possible.
so if there was a reaction, washed blood products will do, or do you go for IgA deficient blood in that case?
If it's available, we can do that too. So it also depends on what we have in store, in stock at the moment, how we need to sort of manage your blood. It's a lot about patient blood management, as you say. So it's also, it needs to.
Thank you.
It's good to have both options, I think. So then we can choose the one that seems most suitable at the moment.
Thank you so much.
Dr. Shalin.
Thank you.
Very nice talk, ma'am. So I just wanted to know whether you do routinely, pre-storage leukodepletion for all your patients, or this is only demand driven, like when the physician is asking for. At the time of collection, do you do leukoreduction for all collections?
Yes, we leukoreduce 100% of our blood products. Actually, I looked at the annual report by the EDQM just the other week, and I saw that finally it seems that in Europe everybody does that on 100%. I was very glad to see it, because, as I said, there's so many benefits of doing it.
And irradiation? That is
only
for
on
oncology patients?
demand.
On demand.
Yes, it's mostly like. It also depends between hospitals, but Karolinska, where I work, we have a large unit for stem cell transplantation. So I would say mainly that's where our irradiated red cells go. But of course, also neonates or anyone with the immune system does not function properly, because this million of leukocytes I talked about, it's not a problem at all if the patient has a normally working immune system, like if it's bleeding because of a trauma or something like that. But otherwise we use irradiation. And actually at Karolinska, where I work, also we support a lot of smaller hospitals that are some quite a distance away from where the blood establishment is, but from where the irradiator is. So we sort of irradiate a few concentrates that we make sure that are always in the local hospital blood bank supplies, because we want to keep it there if it's an emergency and we don't have time to irradiate and send it all the way there. But it's, as I said, it's not good to keep it stored like that for a longer time. So it's important then to keep sort of a short expiring date on that, so you don't transfuse something that could cause more harm than what it gives.
Thank you. Dr. Chirag.
Yes, thank you. This is a question not exactly related to the storage. So let me ask and then see. For patients with warm autoimmune hemolytic anemia, there is a very difficulty in finding a matching unit. And then we end up giving this so-called least incompatible unit. Now, in that process, sometimes takes a long time. And are there any practical suggestions that you can give as to how to reduce time, or what can be done to help this process?
Do you mean that the time is long before you find a matching blood, or?
Yes.
Well, I agree. It's like the everyday situation is always far from ideal, and you sort of need to like play with what you have at your hands at the moment. I would say that we try really hard at Karolinska to keep a stock of frozen blood, of frozen red cells with all these rare antigens or combinations of antigens that are considered rare or difficult to find. So hopefully, if a patient emerges that needs it, we can thaw these bags. we try to do it, and we also have like donors. We screen the donors and look for these rare antigens, so we know that when this donor comes, the bag is marked, so we know from the beginning that we need to freeze this bag instead, because then if you freeze the red cells, the quality isn't as good as if you just keep it in a refrigerator. You lose some red cells, but you don't lose everything, and you can keep it up to 30 years frozen instead. So that's actually a really good option, I think. And we have actually patients that have very, very rare blood types that donate blood sort of to themselves. So instantly it's frozen. We actually mark them as autologous. So it's frozen for them if they need it in the future with their own blood. So it's like this very rare combination of antigens. So I think I would say that's probably the best proactive measure you can take. But still, maybe that like you still can't predict what kind of antigens you're going to have. And sometimes you also see that it's actually, we actually see this in quite a lot in Europe now, because there's a lot of movement in the world. People are moving around quite a lot, both because of political instabilities, but also because it's easier to travel. So we get sort of, our population today is different if you look at the blood groups or the subgroups compared to what we used to have like 30 or 40 years ago. So our donors don't always match the patients perfectly, because the donors it's a lot of like older donors who who don't have these special rare blood types, as we call them, like these rare blood types. They don't match 100%. So we try to actually encourage donation in other. For instance, just some year ago, we introduced that you could donate blood in English instead of in Swedish. And this really helped us getting different donors with different backgrounds and different antigen types. So that was actually something that helped us to get a bit of other blood types into our store as well.
Thank you.
I hope I answer your question.
Yes. One last question, Dr. Radhika.
Yeah. Thank you, ma'am. Thank you, Dr. Linda. That was a very interesting presentation. I just want to check, what is the acceptable maximum time lag between dispatch of red blood cells from the blood bank and initiation of transfusion at the bedside? Because earlier the better, but sometimes if the group is not available with us, the patient may have to get it from a far off distance and all. So what is the acceptable time lag between these two?
For us, we don't separate. We don't really care where the blood is, if it's in the blood bank or if it's going somewhere in a transport box or if it's laying in a local depot. We care about the time between its left refrigeration.
Not in a transport box. In India, like patients do carry like.
Yeah. So as soon as you remove it from refrigerated storage, we have 2 hours that we say that you need to use it within 2 hours, otherwise give it back or make sure it gets into another refrigerator while waiting for the patient. But probably the red cells can last a bit more. It's not, I don't think it's that stringent, but we also try to, at least at my blood establishment, we really try to better safe than sorry. But what you can do actually is that if you tolerate a longer time, you can do it, but you shorten the storage time of the bag if it's not used. So you can sort of change the expiring date if it's not used for the patient. So that's the way of also controlling it, because sometimes there might be blood that has been in room temperature for quite some time and you don't want to throw it all away, because that's also not really good for the blood supply. So yeah, I think so. That's what we say at least. But we sort of encourage that don't remove it from cold storage until you're going to use it. So we don't really like given an exact time because of that, because we want to try to keep it as long as possible. But there's a lot of different ways of looking at this, I'm sure.
The last question, ma'am. Do you also preserve the granulocytes for neutropenic patients in your hospital? I mean, do you separate out the granulocytes and preserve them? I mean, in your blood bank?
Yeah, we are trying, we are working on a method for acquiring granulocytes from whole blood at the moment. We don't have it yet because the validation is taking some time and so, but we are working on it. I know that France has worked a lot with this, so they have really good and established method, and I think they have transfused several hundreds of patients there. So I think they are a good country to look at in granulocytes from whole blood.
Because they can help us out in many of the febrile neutropenic patients and all. So instead of discarding them, probably they can be used up.
Yes, exactly. That's definitely what you can do.
Thank you, ma'am. That was a great presentation. Thanks.
Thank you.
Thank you, Dr. Linda, for that lovely talk and a fantastic question answer session. Very, very impressive. We have.
Thank you. I'm very, very happy to be invited. It means a lot to me. Thanks a lot. I really hope you enjoyed and that I could bring some education to this fantastic webinar, series of webinars.
Thank you. We have Dr. Manoj here to give the official vote of thanks, and I must tell all of us, Dr. Manoj has been instrumental in getting us the sponsorship for this whole series of 7 days of 21 lectures of webinar. I'm grateful to him for that. Over to Manoj.
Dr. Linda Larsson, thank you really a lot. And you're being listened right now from these countries. And I would like to thank the delegates from these countries as well. And they are India, Malaysia, Sri Lanka, Singapore, Bangladesh, Myanmar, Abu Dhabi, Pakistan, Ethiopia, Australia, Sri Lanka, Tunisia, USA, and Africa, just to mention a few. So it's truly a global web series that we are hosting, and thank you indeed to you. You were fantastic. Our earlier two speakers needs to be thanked as well, Dr. Drexler and Dr. Beverley Hunt. They also provided a lot of meaningful contribution to our clinical practice. Our expert discussants today, Dr. Bharat Patodia, Dr. Shruti Kakkar, Dr. Vikas Goel, Dr. Amit Khurana, Dr. Parth Sartha, Dr. Shaurabh Bhave, Dr. Rajat Bhattacharya, Dr. Kunal Goel, Dr. Gunjan, Dr. Jyoti Kodwal, Dr. Krishna Ratnam, Dr. Radhika, Dr. Tejaswini, Dr. Chandran, Dr. Siddharth Shankar Ray, Dr. Shalendra, Dr. Vikas Talreja, Dr. Sanjeev, Dr. Thilagavati, Dr. Amita Chakraborty, Dr. Priyanka Srivastav, Dr. Roshni, Dr. Jagdish Chandra, Dr. Vijita Datta, Dr. Rajat Jain, and Dr. Venkateshan. Please also log in tomorrow. We have 3 speakers, 6:25 sharp tomorrow. Dr. Jan Jaucha from Poland, Dr. Kanu Maddox from Ohio, USA, and Dr. Valeria Santini from Italy. Last, but definitely not the least, a big thank you to our program director, Professor Dr. M.P. Agrawal, sir, teacher of teachers, an inspiration for many. Thank you so very much.
Thank you. Bye-bye.
Good night, everyone.
Good night.